delighted to have today a range of some fantastic speakers who are going to be giving us plenaries and keynotes. Graham Evans from the Integrated Care System is going to talk about integrated medicines. It's great to have Professor Evans with us today. We're going to showcase some really good stuff from around the region with regional colleagues, Gemma, Donovan, Laura Stavert, Calum Polwart, who you all know, I'm sure. And a big thanks to Richard Brown, who's come all the way from Avon LPC to come talk to us about community pharmacy. And it's only right to talk about some of the IT and integration that's happening in primary care and community pharmacy too, as we move to integrated care systems. And our final keynote will be our Health Education England Pharmacy Dean, Dr. Jane Brown, who I'm sure you all know, who's got lots of interesting stuff to share with you. Okay, so without any further ado, I think I've said everything, all the housekeeping. I'm going to start the presentations. I'm going to try and keep us all on time. I'm not very good with time, so this is going to be a bit of a challenge for me. Okay, so this has been a challenging year. This is, we've had one of the toughest years probably in memory. And despite all that, despite the hard work you've all been doing, and despite the hard work the pre-regis have been doing, you still managed to pull out of the bag some fantastic presentations. It was really difficult to choose the 5 that we're going to present to you, because there were just some brilliant presentations out there. So our judging panels and our judging team had a really difficult time. And if I could just take 2 minutes to thank everybody who got involved in scoring and judging the posters, the abstract, sorry, and pick these 5. So please listen to them, please engage with them, please ask them questions. There will be a short Q&A straight after the 5 presentations. Okay, so first up we'll have Megan Blenkinsop from South Tyneside and Sunderland NHS Foundation Trust, who will be talking to us about investigating the effects of COVID-19 on high INR readings. Thank you, Megan.
Hi, I'm Megan, and today I'm going to present my pre-registration project investigating the incidence of high INRs during COVID-19. Warfarin is a widely used anticoagulant and requires patients to have INR monitoring at least every 12 weeks at warfarin clinics. It has many adverse effects, including hemorrhage at high INR readings, and a patient's response to warfarin is affected by many factors, including diet, lifestyle, other medications and comorbidities, and more recently, COVID-19. The aim of my project was to investigate the relationship between the incidence of high INR readings, specifically at 8 or above, and COVID-19. More specifically, my objectives were to identify how many patients had INR readings at 8 or above between March the 23rd, 2020, this was the date of the UK's first lockdown, and the 5th of January this year, and identify how many of these patients were positive for COVID-19, and to determine whether high INR readings were more prevalent in specific patient groups, such as male patients, older patients, or ethnic minorities, and to determine what factors have affected INR readings during the pandemic. For my method, all warfarin clinic patients and domiciliary visits who had INR readings at 8 or above during the study dates were included. I identified these patients using the report function on INR Star, and then for data collection I accessed each INR Star and Meditech record and collected the following factors shown on screen. Now on to the results. 33 patients aged between 28 and 91 years old who all had an ethnicity of white British were investigated in the study. Only 3 patients tested positive for COVID-19 prior to their INR result. Most patients had several additional factors affecting their INR reading as shown on the screen, with 3 patients having no known reason for their high INR reading. So what do these results show and how do they relate to other research? Age was shown to be statistically significant in the study, as over half of the patients were aged 70 years old or older. This has also been shown in recent studies, with changes in pharmacokinetics in the elderly population being a substantial factor in warfarin dosing. However, the age of a patient is not affected by the pandemic, as there is no conclusive evidence that INR readings are affected by COVID-19. Likewise, with regards to COVID-19 infection, 3 patients have received a positive COVID-19 test when they received their INR reading at 8 or above, which has also been shown in a recent study. However, some researchers have proposed that COVID-19 could actually increase your risk of a clot rather than raise your INR reading, and as only 3 patients received a positive COVID-19 test prior to their high reading, it is not possible to associate the 2 factors together. Gender was also investigated in the study, as researchers found that COVID-19 disproportionately affects more men than women with regards to fatalities, but as the number of positive COVID-19 cases in the study was not significant, an association between high INR readings and COVID-19 could not be determined, so we cannot determine whether this is affected by the patient's gender. Likewise, as 100% of the study population were white British, no separate analysis by race or ethnicity could be carried out. Now on to lifestyle changes during the pandemic. 3 patients studied in the investigation had changed their alcohol consumption. This may be due to the pandemic, as for some patients, restrictions meant they reduced their alcohol consumption. Differently, some patients may have increased their alcohol consumption, as researchers have revealed there has been a significant increase in alcohol sales during COVID-19. Also, 7 patients investigated in the study had diet changes that they attributed to the pandemic. This could be due to stockpiling or government restrictions. Moreover, reduced vitamin K levels have also been reported in COVID-19 patients, and both weight loss and malnutrition can increase warfarin sensitivity. However, it is important to note that lifestyle changes can happen at any time and cannot be explicitly attributed to the pandemic unless documentation on INR staff specify this. Moving on to medication changes. 11 patients were diagnosed with new medical conditions leading to medication changes, with a large proportion of those due to antibiotic use, which has been emphasised in a recent study. 4 patients in the study had changes to their analgesia, mainly attributed to paracetamol, which can increase warfarin sensitivity, and 4 patients had changes to their warfarin doses, which may have affected their INR reading. Patients can be diagnosed with new medical conditions or have dose changes at any time. Thus, it's not possible to associate these changes to the pandemic unless the changes are due to a positive COVID-19 test. However, prolonged INR monitoring by 2 weeks at the Trust may have led to patients taking incorrect doses for a longer period of time. To conclude, the study results provide no evidence that raised INR readings are due to the COVID-19 pandemic. Current research is limited, thus further studies are needed. PT and INR monitoring could be carried out in all COVID-19 positive patients, not just warfarin patients, to assess the risk of hemorrhagic events in order to get a larger sample size with different ethnicities. And local results could also be compared to the rest of the UK, and the amount of high INR readings can be compared to the same time period the previous year when the UK was not in a pandemic. In practice, pharmacists must confirm patients' warfarin doses and their warfarin clinic details so they can notify clinics of any changes, allowing healthcare professionals to access the need for more frequent INR monitoring. Thank you.
Thank you, Megan. That's fantastic. Great presentation. Well done. If you've got any questions for Megan, please keep them coming in the chat box and we'll pick them up afterwards. Our next presentation is an audit assessing the appropriateness of controlled drug destruction and its relevant documentation by Aidan Fowler, pre-registration pharmacist at North Tees, Hartlepool NHS Trust. Thank you, Aidan.
Hi, my name is Aidan Bowler. I'm the pre-reg pharmacist at North Tees Hospital, and this is my audit assessing the appropriateness of controlled drug destruction and its relevant documentation. So firstly, a bit of background. So in June 2015, there was an NHS-sponsored study estimating £300 million of prescribed medicines were wasted a year. This includes care homes, this includes what's been brought to community pharmacies from patients, this includes hospitals. We wanted to look at how much we save from returns within a 6-week period, because that's the time frame we had. So our trust saves roughly £10,000 from non-controlled drug returns within 6 weeks. So then we wanted to look at how much we could save if we were returning controlled drugs always appropriately. So firstly, we had to produce some standards to assess against. We did this reviewing our SOPs and seeing how we can link them in. So firstly, we have, is each drug intended for destruction recorded into the CD destruction register appropriately? And secondly, we had CD medication being checked against this criteria. So any that were put into the destruction book were assessed against this criteria. If it met any of these criteria, it was suitable for destruction. And if it met none of this criteria, it actually could have been returned rather than destroyed. So here we have patients on drugs less than 6 months expiry, in poor condition, etc. Next, a bit about our method and how we did it. So all our data was collected over a 6-week period, as this was a suitable time frame for us. Records of all controlled drug returns stored for destruction in pharmacy were assessed, and to see if they had been written in the destruction register according to trust policy. So this included going through the CD drug cupboard and just reviewing every CD, whether it had been written into the register. And then once it had been written into the destruction register, We looked to see whether it met any of the criteria in standard 2, and if it did, that meant it was suitable for destruction. If it didn't, we actually noted these medications down and we analysed them on our prescribing software, which is a scribe. And when we looked at this, we assessed the cost of all the drugs that we destroyed, all the drugs that could have been returned but instead were destroyed, and got a total costing. So in terms of results, we had 7.3% of CDs for destruction were not recorded in the destruction book, as can be seen here. So they were left in the CD cupboard and they weren't accounted for in the register. Whether someone was going to come back around to these later, we weren't sure for every single medication, but it's important they're documented. Secondly, we looked at which CDs could have been returned, but instead were put for destruction. 22.9% of the drugs that could have been returned rather than destroyed. So in total, we had a costing of £60.32 of CDs that could have been returned, but were instead destroyed. We had our price of our dupe kits, which was £80.52, and cost of labour. We assumed that this was band 5s working for 2 hours for 4 band 5s. Realistically, there's a mix of skill set, but we just did this as it was a fair middle ground. We got a total cost for the destruction process that could have been returned, which was £319.20. Then the total cost of all drugs destroyed that day was £782.08. As you can see, there might be some higher cost drugs there, which could have had a large impact on our savings if they've been returned. So this moves us on to the conclusion. As I said before, there was limitations with high cost drugs. I think a large amount of that may be to do with COVID and high-risk patients maybe not wanting to come into hospital, and some of the more expensive control drugs not being dispensed. If you looked at an entire year, I think there'd be a lot more high-cost drugs that could have been returned, therefore would have large impacts on our savings. We then looked at how we could improve this. So implementing more education around the topic of waste management and assessing CD returns. This included pharmacists and technicians. Secondly, reviewing the SOP policy, which we have actually done and updated to make more appropriate. And thirdly, having a returns checklist on the cupboard so everyone adheres to the standards more regularly. I then also asked others how they thought we could improve, given my information. They said help technicians with returns would make a large impact, and reviewing over-prescribing of CDs themselves. If there's less over-prescribing when unnecessary, there'd obviously be less returns, which could have a large impact. I also came up with a fun little game to see who could get closest to guessing how much we'd wasted, and the numbers were between £400 to £7,500. So it shows a clear lack of understanding around control drugs, around how much they cost, and there could be a lot more education around this topic. Thank you for listening. I hope if you have any questions, I can answer them later on.
Thank you, Aidan, for the fantastic presentation. Okay, so next up, we've got Caitlin Madden, pre-registration pharmacist at the Cumbria Healthcare NHS Foundation Trust. And Caitlin was a cross-sector pre-reg who worked with a general practice as well. And her project is audit assessing the appropriateness, evaluating the quality of patient follow-up in post-myocardial infarction. Thank you, Caitlin.
Hi, my name's Caitlin, and my project was based in primary care, where I assessed how well we follow up patients post-MI by looking at the up-titration of ACE inhibitors or ARBs. I'm going to refer to them as just ACE inhibitors today for ease, and beta blockers. So around 1.4 million people are alive today who have survived a myocardial infarction, and the cost of an acute MI is around £4,000, and the cost of an acute exacerbation of heart failure is around £3,000. And 95% of these costs is based on the actual hospitalisation itself. So the initiation of ACE inhibitors and beta blockers have shown to improve cardiac function, improve a patient's quality of life, and reduce hospitalisations and deaths. So these medicines have been shown to work most effectively when they are used at optimal doses. And by that, I mean greater than or equal to 50% of the maximum BNF dose. And this is compared to suboptimal doses, which don't work as well, which is less than 50% of the maximum BNF dose. Therefore, NICE recommends initiating these therapies post-MI and titrating to the maximum tolerated dose within 6 weeks for ACE inhibitors and within 11 weeks for beta blockers of discharge. And these are a cost-effective way to reduce hospitalizations and improve patients' quality of life. So this NICE standard is what I used as my audit standard. So to assess the extent at which we follow these guidelines, I conducted a system search of patients within the GP practice with a patient population of 19,000 of those patients coded within the GMI in the past 12 months. So this identified 26 patients, of which 23 were eligible for ACE inhibitor and beta blocker therapy at discharge. However, only 3 and 2 patients were at maximum doses of these, respectively. So, of these patients which were not discharged at maximum doses, none of the patients achieved maximum doses of either ACE inhibitor or beta blocker within 6 and 11 weeks, respectively. Therefore, all the patients failed to meet the audit standard. However, interestingly, a heart failure nurse followed up 3 of the patients, all of which achieved maximum dose of ACE inhibitor or an ARB and at least 1 increase in the beta blocker by 6 months. And this kind of suggested that potentially there is a bias towards patients who are followed up by a heart failure nurse. So just to the graphs, figure 1 shows how many was the percentage of patients who achieved at least 1 attempted increase in their therapy at 3 months and 6 months post-discharge. So for ACE inhibitors, as you can see, around 25% at 3 months received an increase. And then at 6 months, this increased to about 30%. So only an additional 5% joined this list. So it's a cumulative graph. And beta blockers were similar, except that obviously at 3 months, there was a lot less patients who had received an attempted increase in their therapy. So I wanted to look at attempted increase because obviously drugs may not be tolerated, so at least an attempt had been made to improve their therapy. So figure 2 shows the mean percentage of the maximum BNF dose that a patient was prescribed at each time point. So this refers to, again, to them optimal doses. So we're looking for greater than 50% of the BNF maximum dose. So as you can see, even at 6 months, on average, everyone was less than 40% of both therapies, less than kind of what the evidence shows they should be at. And as you can see, the standard deviation is very large for these data. And that is because there was a widespread of kind of doses that patients received. So you often saw patients that were just kept on either no therapy or small doses for the whole 6 months. And then you saw other patients who received kind of maximum doses early on. So kind of these were the patients who appeared to be were followed up by heart failure nurses. And then figure 3 just shows kind of the percentage of patients on the maximum doses. So as you can see that beta blockers, it was the same patients at discharge and at 6 months, and at ACE inhibitors, there was a little bit of an increase by about 10%, which was just 1 patient or so at 6 months. So as I mentioned before, there appears to be kind of this bias towards patients followed up by heart failure nurse, suggesting that they get a better standard of care than those not followed up. And in regards to kind of previous research in the field, previous research in the UK has shown that between 46 and 48% of the maximum dose of ACE inhibitor is achieved at 3 months, whereas our practice showed at 3 months on average it was 26%, which is much less than the average previously discovered. And then likewise for beta blocker therapy, it was shown that 34 to 41% of the maximum dose has been achieved at 3 months, and ours was only 28%. So in conclusion, the kind of up titration within the practice was below the UK average previously reported. And And the average dose, this kind of most importantly, the average dose that patients received was below the optimal dose shown to reduce hospitalisations and reduce mortality the most. So none of the patients met the audit standard, i.e. none of them met the maximum tolerated doses within 6 and 11 weeks respectively. And it did appear that there was an apparent bias towards patients who were followed up by heart failure nurse, resulting in different standards of care being delivered depending on whether you received this follow-up or not. So with this in mind, we're in kind of discussion with both our primary care and secondary care colleagues on ways to improve the way we follow up these patients and to try and create a fairer system so that no patient is left behind. Thank you very much for listening. I hope you enjoy the rest of the conference.
Brilliant. Thank you very much, Caitlin. Excellent presentation. Next up, we've got Sabrina Mahmood, who will be looking at an assessment of the electronic documentation of medicines reconciliation. Thank you, Sabrina.
Hi, my name's Sabrina, and this PowerPoint is about my audit, which was assessing the electronic documentation of medicines reconciliation. So firstly, just a little bit of background. Medicines reconciliation aims to reduce the risk of harm due to medication omission or inappropriate prescribing. NICE published a medicines optimisation report in 2015, and it found that there was a 30 to 70% unintentional variance between medications patients were taking pre and post admission. Obviously, documentation is a crucial part of the medicine reconciliation, and an effective SOP should facilitate this. So why did I choose to do my audit on this topic? Well, North Tees Hospital, where I'm currently doing my pre-reg, changed from paper-based to electronic MR a few years ago, and they approved a SOP to facilitate the change, but there's been no review of its effectiveness since its implementation. So what were the aims and objectives of my audit? Well, number one, to assess documentation of medicines reconciliation on the Trust electronic notes according to the SOP. Number two, identify common problems with recording medicines reconciliation electronically. And number three, evaluate if the SOP that we currently have in place requires any review. So what was the method used? Well, it was a retrospective study. 2 different MR records from each adult ward in the hospital were reviewed daily between the 1st of February and the 5th of February. Ethical approval wasn't required because we were just reviewing medicine reconciliations that had previously taken place. Case numbers were used to identify patients at random, and each medicines reconciliation was audited by the author, which was me. So I created 8 audit standards which were taken from the SOP itself, and we use these to audit against. So number 1, pharmacist/technician should speak to the patient when appropriate. Number 2, a summary of the final drug history must be recorded. Number 3, any discrepancies between the list compiled and drugs prescribed should be documented. Number 4, problems requiring further investigation or intervention should be documented. Number 5, information regarding allergies, sensitivities or any adverse drug reactions should be documented within the MR itself. Number 6, pharmacist/technician should document clearly if the patient receives a NORMAD, and details of the patient's pharmacy should also be recorded. Number 7, details of any acute medicines should be recorded. Number 8, details of the care home should be recorded when appropriate. So this is a graph of the results. On the left-hand side, you have the audit standards, and on the right-hand side, you have the percentage of medicine reconciliation that match the audit standards. So blue is documented and orange is undocumented. So firstly, of the 120 medicines reconciliations that we audited, 0% met all of the standards. Findings from Standard 1 showed that 78% of pharmacists/techs didn't document speaking to the patient to establish the drug history. Standard 2 achieved the best results with 100%, as all drug histories were documented on the system correctly. Standard 3 found that only 34% of medication discrepancies were clearly documented, and Standard 4 showed that documentation of problems that required further investigation achieved only 2%. 79% of the allergies were not documented within the medicine reconciliation itself. However, they were always documented elsewhere. Of the 33 nomad patients that were identified for Standard 6, 69% were recorded correctly. Standard 7 showed that 62% of acute meds weren't documented, and for Standard 8, of the 24 care home patients that were identified, only 9% had their details documented correctly. So the conclusion, the SOP itself states that discrepancies can be communicated either verbally or via documentation and medical notes, but interestingly it also states that verbal communication is preferred for timely action. So on observation, it was noted that most interventions were verbally resolved, and this is probably reflected in the poor results for audit standards 3 and 4. There's also no requirement to document speaking to the patient to establish drug history. So for Standard 1, most people probably did speak to the patient, but it's just not documented. There's a clear need to amend the current SOP to clarify necessary elements of the documentation combined with a relaunch and a re-audit after 6 months. Stipulation between desirable and essential documentation criteria is needed. This study was conducted during winter pressures and COVID-19, where quality of care was not compromised, but documentation certainly could have been. Another limitation is that verbal communication wasn't quantified. So the implementation of electronic recording is relatively new, and the pre-existing SOP requires review, and further clarity is required to determine which information must be documented and which shouldn't.
Fantastic. Thank you very much, Sabrina. That's really good presentation. And our final presentation is from Hannah Macmillan from North Cumbria Integrated Care Trust, who will be talking to us about auditing the prescribing of oral tetracyclines for the management of acute acne in patients in a GP surgery. Thank you, Hannah.
Hello, my name is Hannah, and my project involved auditing the prescribing of oral tetracyclines for the management of acne in patients over 12 years old in a GP surgery. Skin conditions account for 8% of primary care antibiotic prescribing. The clinical commissioning group for the GP surgery assesses antimicrobial resistance and the appropriate prescribing of broad-spectrum antibiotics in primary care. Acne management involves a stepwise approach. As shown in Figure 1, first-line treatment for mild to moderate acne involves a topical retinoid such as adapalene, alone or in combination with benzoyl peroxide, for example, Epiduo gel. For those with moderate acne unresponsive to topical treatment, adding a tetracycline such as limacycline or doxycycline for a maximum of 3 months should be considered. Once complete, maintenance therapy should resume with a topical treatment. Topical treatment should always be co-prescribed with an oral antibiotic to reduce the risk of antibiotic resistance. There is little additional benefit of using antibiotics for more than 3 months, and oral antibiotics are less clinically effective when used as a monotherapy. The standard for this audit was that 100% of patients receiving oral antibiotics to treat acne are co-prescribed a topical agent by the 8th of the 3rd, 2021. This was to allow enough time to gather data and make an intervention where necessary. A search was conducted using the EMIS patient database to identify patients prescribed oral tetracyclines for acne within 6 months from the search date of the 28th of the 1st, 2021. It was identified whether a topical treatment was co-prescribed. This data was tabulated with patient information partially anonymised and the data collection form stored on a password-protected device. As the audit was part of the medicines review process, no ethical approval was required. The initial search identified 15 patients prescribed oral antibiotics for acne. 2 of these patients were co-prescribed a topical treatment, equating to just 13%. Therefore, 87% of patients were not prescribed acne treatment according to NICE guidance. An intervention was conducted to meet the standard. Telephone consultations were held with patients who met the search criteria to determine whether treatment with oral antibiotics was still indicated, to offer topical treatment where needed, and inform them of the guidance. As a result, many agreed to step down to maintenance topical therapy. Following the intervention, 75% of patients prescribed an oral antibiotic for acne were co-prescribed a topical treatment. This is a 62% improvement from the initial audit value, which is displayed in Figure 2. Additionally, as a result of the consultation, 80% of patients were prescribed an appropriate treatment for acne that followed NICE guidance, as shown in Figure 3. Limiting factors impeding full achievement of the standard include one patient being uncontactable and previous intolerance to similar topical treatment, which reduced willingness to try epidural gel. A teaching session was also provided to inform prescribers of the guidance. Future plans to continue to improve the correct prescribing of acne treatment include creating a pop-up alert on the EMIS database to notify prescribers of the guidance and prompt treatment reviews in 3 months' time. The GP practice also plans to re-audit in 12 months to ensure the maintenance of the standard. Thank you for listening.
Thank you, Hannah. Brilliant presentation, and actually excellent presentations from all 5 of our pre-registration colleagues today. So, and lots of rounds of applause on the screen there. Fantastic, great feature on Teams, if I could ever find it quick enough to use. Okay, so can I have our pre-registration colleagues, Megan, Aidan, Caitlin, Sabrina, and Hannah online, please? Hello, everybody. So, lots of questions on the chat for you guys. So, Megan, can I start with you? You had quite a small sample size. What could you do differently to increase your sample size? And could you say something a little bit about the patients that were excluded, for example, those on DOACs?
Yeah, so obviously one of the biggest limitations of my study was the small sample size. Actually, anyone that had an INR at 8 or above was included, including those people that actually were switched to DOACs. So 6 people in my study were switched to DOACs, but they were still included because at the time they were on warfarin and they still had the INR at 8 or above. And I think, I can't remember off the top of my head, but I do feel like maybe 1 or 2 were actually positive for COVID-19 as well. So it did obviously, it was relevant. With regards to having a bigger sample size, I only looked at patients in warfarin clinics, so actually looking at patients as inpatients. We obviously had so many COVID-19 patients, many of them may have been on warfarin, so their INR values actually have been overlooked. I didn't collect inpatient data, so that's something to increase my sample size. Maybe obviously going away from INR monitoring and looking at PT monitoring, because obviously PT affects everyone, not just people on warfarin, and looking at actually whether COVID-19 affects our ability to clot and seeing if that affects whether hemorrhagic events happen.
Yeah, really good answer, and thank you for your presentation. Oh, but just before you go, did you consider compliance at all? Was that something that you thought about?
I did, yes. So it was obviously something that didn't show up on INR Star. No one really said whether people had missed doses or not. But what I did think obviously is we're in the middle of a pandemic. Obviously everyone's been social distancing and shielding, and that could have had quite a negative impact and obviously affect compliance, whether that's attending their INR appointment or attending their pharmacy to pick up medications as well. Yeah. Maybe they're not getting them delivered to their home. So that's something I did want to look at, but unfortunately wasn't able to assess. Yeah, definitely.
Brilliant. Thank you very much. Aidan, can I come to you next?
Yeah.
Hi there, well done and great presentation. So can I ask, what did you get a sense of why CDs were being returned? Was it over ordering? Any insight? Did you get
I think part of it's just they tend to do it in a big batch, so then you spend a lot of your morning doing it, and when you need it on the ward to do discharge and medrecs, it's hard to find that time to get away. I think that's part of the reason. One of the big recommendations was getting techs involved. If techs can get involved, then it's split the work and you're not wasting as much time doing it, and therefore you've got time to still look at the patients on the ward. So I think a lot of people put it off as a job because they need time on the ward.
Yeah, sure. And just on that note then, having techs involved, a great question from Julia about the balancing measures, the metrics for change, the extra resource needed versus the you need versus using the systems.
Yeah, so what I'd say for that was a lot of the time you're either going to be destroying it or you're going to be returning it. So either way, you're going to have a process where you're taking a decent amount of time filling in a book or putting it back into the system. You've also got people checking the balances, but when you're looking at the balances, we've got Omnicell, so it's not actually that large of a job to check the balances. Yeah. It does it for you. So the amount of time I actually spent doing it wouldn't drastically change if you were returning it or if you were destroying it. So realistically, I think it wouldn't drag time away from other places and it wouldn't have a large impact on other roles. I'm sure there's some other things to consider where it might have an effect or impact, but I haven't considered any of them as of yet.
Yeah, of course. No, that's great. And thank you very much for your presentation today. Caitlin, can I come to you next? Some questions coming up here about the barriers to this. Why is this not happening?
I think there's multiple reasons, really. Kind of the fact that patients are going through both Newcastle and Northumbria. Obviously, different organisations and different kind of communication isn't always the best between places. And then quite often you'd see on the discharge kind of just the generic, please like up titrate to maximum tolerated dose. But kind of on the computer system, like the system one within the practice, like there was never kind of any follow-up, there was never kind of scheduled task or anything like that after someone has looked at the letter. So I think it's because obviously you can't see the immediate benefit of this. So kind of perhaps that's not prompting healthcare professionals to kind of follow this up, right, because you can't see that kind of immediate benefit.
No, that's really helpful. And then another sort of common theme coming through in the questions was about outcomes. Was there adverse outcomes as a result of this? Did you look for that, like hospitalizations, events?
So obviously in the patients I was looking at within the practice, I didn't look that far as to whether patients were kind of hospitalized recently, but kind of all of the research shows in the field that having them above 50% of the dose reduces hospitalizations, exacerbations, and like deaths related to heart failure and heart disease.
Yeah, that's brilliant. And thanks again for your presentation.
Yeah, no worries.
Okay, so Sabrina, interesting presentation, and really, I've got a bit of an interest in care homes, and also our colleagues on the chat. So it's really interesting that finding that 91% of patients had missing documentation for care homes. What do you think was driving that?
Well, actually, I was really strict when auditing. So if it didn't include the pharmacy address or number, then I also said they hadn't carried out put all the information there. So a lot of the time it was they'd identified that they were a nomad patient, but they didn't put their community pharmacy, or they didn't put the community pharmacy telephone number, so you could get in contact if you had any further queries. So yeah.
Yeah, and what sort of actions have you guys taken as a trust to sort of tackle some of your findings?
So the SOP is getting rewritten. I think with the electronic documentation, because it is very new, there's a lot of problems within the system itself. So like for allergies, they never actually documented in the medicine reconciliation, or not very often, which is what the audit found, because there's actually a separate tab for allergies. So often the pharmacist will go into that tab and put the allergies in there rather than in the medrec itself.
Right.
That's also the case with some of the problems. They'll write in the medical notes rather than in the medrec. So then the doctors are aware of what medication changes might be needed. Sure. So I think it's putting them steps in the medrec to make it easy for everyone, rather than going to loads of different places to find the information.
No, that's a really good point. And finally, what sort of additional risks do you think electronic prescribing will bring? You'll solve some problems, but what other problems do you think you might have as a result of having an electronic system as opposed to a paper-based system?
I think electronics are amazing when they work, but when they don't work, it's a really big issue.
Sure.
So yeah, I mean, we've had it in the hospital before where the system's been down, and that at that point, what can you do? So it's fantastic when it works. I think there's a lot of tweaking that needs to take place to make sure it's up to the standard, because paper-based had been around for a very long time. Everyone had standardised sheets, and it's transferring that to electronic to make sure the same quality is there.
Yeah, no, really good. And we have the same issue with electronic conferences. Brilliant, thank you very much. And finally to Hannah. Hannah, did you sort of come across sort of any barriers to change, and what sort of communication skills, decision support aids, that sort of stuff, what do you think would have been helpful for the healthcare professional?
Yeah, so I was very aware when doing my project of the psychological distress that acne can cause patients. So I was very keen to avoid causing any more by disturbing people's treatment. However, I made sure that I gave clear information about the topical treatments that patients would potentially be adding on to their oral therapy, and also give information about the risks of antibiotic resistance if with continued oral therapy. And I think because of patients are a lot more aware of antibiotic resistance, they were quite receptive to try and help to reduce this. And also the fact that emphasising that actually using dual therapy is more effective for their condition was actually something that made people more receptive of adding the add-on therapy.
That's really good. And just a question about standards, audit standards. Would you set them at 100% next time if you de-audited this?
Yeah, I think the 100% is probably quite high, and I probably didn't consider the fact that some people may have had previous intolerances to using similar topical treatments, and also that some patients have had dermatologist input as well, so which wasn't always documented in the notes. So maybe a slightly lower standard, but I thought in an ideal world it would be nice to have everybody have the golden standard, really. So that's why I chose 100%.
And just an interesting point from Gemma Donovan just on text here about that antibiotic resistance being a motivator for patients. Do you think that this is now finally filtering out into the psyche of the population, that this is a bad thing?
I think a little bit, yeah. When I mentioned it, because it was more of a that was something else. It was more of a conversation with patients rather than me telling them this is what is going to happen. So it's quite interesting to have a discussion, and I think actually patients were keen to not have an impact on the causing more antibiotic resistance. So I think it's actually something that, as more patients are becoming more aware of and actually are interested in the cause, I think.
Brilliant. Well, listen, thank you all 5 of you for some amazing presentations. Great piece of work. No doubt a lot of hard work's gone in there to put it all together, and then just because you were so good, you had to present it again. So it seems very unfair. And so maybe one of those electronic rounds of applause for our 5 speakers today would be great. You're a credit to your organisations, and I wish you all the best going forward. So great to have with us for our next session, our keynote speaker, Professor Graham Evans. Professor Evans is the Chief Information Technology Officer for North Tees and Hartlepool NHS Foundation Trust, and the Chief Digital Officer for North East and North Cumbria Integrated Care System, our ICS, as well as a Honorary Professor at Teesside University. So Graham, absolutely wonderful to have you here today. I know that your presentation is pre-recorded, but you're going to be here answering questions and engaging with our delegates. So thank you for that.
Hello, my name is Graham Evans. I'm the Chief Digital Officer for the North East and North Cumbria Integrated Care System, or ICS. I'm also the Chief Information and Technology Officer at North Tees and Hartlepool NHS Foundation Trust. My presentation today will focus on integrated medicine in the digital age. By way of introduction, I intend to give the context and the evolution of the ICS, followed by some headlines relating to the North East and North Cumbria ICS digital strategy. I'll then move on to focus on medicine in a digital age, with a specific spotlight on pharmacy and its associated services. From this, I'll give an overview of a case study relating to North Tees and Hartlepool NHS Foundation Trust. And then finally, there's an opportunity at the end of this presentation to ask some questions that hopefully I can answer. In terms of our regional context and the North East and North Cumbria ICS evolution, we are the largest ICS in England, serving a population of approximately 3.2 million citizens. Due to our size and scale, we have subdivided our region into 4 localities, integrated care partnerships, or ICPs, as they're currently known. Regionally, we have a long legacy of collaborative working. Digital is one of 6 ICS priority work streams. We describe our ambitions in our digital care programme, illustrated in our digital strategy and its associated roadmap. All of our regional digital leads and chief information officers work regularly in a networked manner, focusing and supporting our flagship programs. My role as Chief Digital Officer is to support the digital care programme, direct the strategy and coordinate delivery. Our strategy has been more recently influenced by the Integrated Care Next Steps document and the recent publication of the Integrated Care Systems Design Framework. In terms of the priority work streams within the ICS, we have 6 which focus on a number of key areas of importance: improving population health and preventing ill health, optimising health services, mental health and learning disabilities. But below these work areas, we have a couple of enabling work streams: workforce transformation, and central to this, digital transformation, which is about making the best use of technology, data and IT to ensure efficient and effective service delivery. We published our first ICS digital strategy back in 2019, and this is broadly based on the ambitions set out in the NHS 5-year forward view. But since that point, the NHS long-term plan, the NHS people plan, more recently the ICS design framework, and the impact of a global pandemic allowed us to reflect on what we were planning to do and update that, which has now been described in the publication of our new ICS digital strategy. Our ICS digital strategy can be found located on the ICS website. The hyperlink is on the screen for colleagues to follow at your leisure. Within our foreword, we describe our ambition and our future direction. One of the unique features of this document is its co-design and co-production, so much so that we have co-signatories from both health and local authority partners. The document is a relatively light read. There are only 24 pages, and the simplicity of its navigation can be found through a dynamic navigation pane. In terms of its context, we set our national ambition, our regional ambition, and some of our local priority areas. Our vision for our digital services is to enable the delivery of high quality, easily accessible and efficient health and care services to the people and the population of the North East and North Cumbria through digital solutions. We recognise that the world of technology is rapidly changing. What may be an idea today may be reality tomorrow, but the day after may be out of date. And therefore, we expect that this document will be continually updated and refreshed in an agile manner. The development of the document was in co-production with a whole range of regional partners, from health, local authority, voluntary and third sectors. We truly believe that this was an ambitious programme that we all worked together to deliver. Interestingly, we actually produced our second strategy document during the peak of the global pandemic. This was all done through virtual tools and collaboration capabilities. Essentially, we try to work and lead by example. Our key themes within the strategy are about getting the basics right, ensuring that the essentials are in place, continually improving our ambitions and our agenda, connecting our organisations internally and externally, and perhaps beyond. We want to continually learn with everything we do, but also learn from things that others do. We want to empower our staff and our citizens or patients to be more involved in the health and care agenda and utilise digital tools and services to greater effect. For each of our themed sections, we describe the things that we are planning to do and also the things that we've done, and from this we can learn and share appropriately and accordingly. We have recently undertaken a rigorous root and branch review of the ICS digital governance arrangements, and I'm pleased to say that all of those arrangements are now in place. Whilst we expect there may be some requirements to change from April 2022 onwards, we feel that our digital governance arrangements are relatively future-proofed. Our digital roadmap illustrates the things that we've delivered, the things that we are then planning to deliver in the medium to long term. Many of our recent deliverables have been helped by the innovations facilitated through the COVID pandemic. We need to keep our eyes on the future given the dynamic nature of the digital evolution, most of which has been driven by miniaturization of technology. Clearly, digital by default will be our ambition, but we're also realistic, and we need to make sure that our solid foundations are in place first of all. Whilst our strategy is relatively high level and directional, we want to use this as a blueprint for our places and our organisations to then use as a blueprint for their own ambitions and deliverables. We want to try and use this in order to vertically align our health and care system. The key thrust of our digital strategy has been based on some of the ambitious deliverables outlined in the NHS long-term and people plans. How we can improve digital interactions through consultations in primary and secondary care. Can we use new models of care enabled by technology? And how we can improve personalisation and self-care, again, using digital tools and capabilities. From a secondary care point of view, we need to ensure that we've got good and solid digital infrastructure to allow all of our trusts to be fully digitised by 2024. We want to make sure that we build privacy and security by design and develop standards for interoperability. We then want to continue the development of our ambitious shared care record programme. We're in the very fortunate position within the ICS to have a number of global digital exemplar organisations. These are organisations that are on par with the best and most mature organisations internationally. But conversely, we have a number that require significant digital investment in order for them to level up. What we've also done is seen examples of the rapid adoption of technology through the COVID pandemic and its response. And many of those services that were being planned for delivery in the future are now available and working as business as usual. All of our strategic digital programs put the patient or the citizen at the centre. This includes some of the ambitions described within the Great North Care Record plan, how we can improve our point of care delivery, how we can ensure that patients are able to engage through an appropriate technology platform, and how we can use technology and data to improve operational and research capabilities. Furthermore, how we can use technologies to improve our diagnostic services, through digital imaging for pathology, haematology, and radiology services and its networked capabilities. We have a large-scale, ambitious regional program to deliver self-management and self-care pathways through our health call offer. And furthermore, we're working together collaboratively to improve our laboratory information management services across the region. These are just examples of some of our crown jewels or strategic digital programs, and there are many other priority digital programs evolving almost by the week. But our strategy has to be about delivery. We can't just go on talking about what we might do, it's about what we are doing. There is obviously some unintended consequences of digital delivery, not least the fact that the more digitally dependent we become, the bigger the threat for cyber attack. Furthermore, we realize that not all people are digitally connected, and we don't want to expand or make the gap wider for digital exclusion. So we do need to think about how we offer those services to the parts of our system that are not able to access digital services for whatever reason. But we do know that within the ICS Next Steps and Design Framework and the recent planning guidance, it's all about digital not being an option, but necessity. But we do need to think like a patient and act like a taxpayer. Put your mind in the part of a patient, but make sure that we are not wasteful when we invest taxpayers' money in our delivery services. So I'll now just like to focus on medicine in a digital age and specifically look at pharmaceutical services. And I think it's worthwhile just reflecting on what is the actual problem we're trying to fix. And we do know that paper-based systems and records are inherently unsafe and inefficient. We know that they cannot meet the demands of a modern healthcare system. It does present a whole range of inherent risks in regards to patient safety, and it's highly cost ineffective. It doesn't provide the visibility that we need for performance purposes, and it does not help decision making and ownership. We know that even as far back as 2001, as a result of the Spoonful of Sugar report by the Audit Commission, that many patients are known to suffer through adverse drug errors, and that many lives could be saved if we were able to fix those problems. Each adverse error would extend the number of days that a patient has to stay in hospital, and there are massive direct cost implications when we get things wrong. There's a significant year-on-year increase in reported adverse drug errors, and 76% of this, even back then, was attributable to acute care provision. We know that documents that are handwritten can often be illegible, they can be ambiguous and incomplete. We waste a lot of time trying to locate and decipher information, and we know that many medications are missed or even late, and it's about being inconsistent and having poor recording and checking. Overall, it just isn't good enough. Many colleagues will be familiar with documents such as this, and they are really difficult to interpret and make good and sound clinical decisions. And interestingly, the author Mark Twain wrote quite an interesting quote, which is along the lines of, he wrote in a doctor's hand, from which the beginning of time has been so disastrous to the pharmacist and yet so profitable to the undertaker. Something to think about. So what has digital done for medicine? And it's at this point I'd just like to reflect on a case study from North Tees and Hartlepool NHS Foundation Trust. North Tees have had a history of innovation within digital medicine. We were one of the first organisations to deploy ward-based pharmacy technicians using software and computers on wheels, and to have ward-based pharmacy technical services. This was a key recommendation from the Defining Spoonful of Sugar report. In order to set the scene for the North Tees and Hartlepool case study, from a local context, The Trust has an annual turnover of just over £326 million. We serve a population of around about 400,000 citizens. We employ approximately 5,600 staff, and we operate from 2 main hospital sites plus a smaller community hospital. We are currently rated as a Care Quality Commission or CQC good organisation, but have an ambition to move to outstanding as quickly as possible. We've recently published our corporate strategy, and from this we have a number of enabling strategies, one of these being a digital strategy. And the key theme within the digital strategy is to continually raise our levels of digital maturity, having a very clear vision and ambition, but with a robust and practical delivery plan. But in order to drive that ambition, we first of all need to know where we start from by setting a baseline, and then ultimately where we want to get to. And if we are then able to measure that progress, we can certainly deliver it quickly. But it's not all about the technology. Our digital strategy talks about how we include both people, process, and technology in order to succeed. As I've said previously, it's about building those solid foundations, the good, robust digital infrastructure. Then how we deliver a whole range of clinical and line of business services. From a clinical perspective, central and core to this is the delivery of an electronic patient record. And in our case, this is the InterSystems Track Care platform. Within Track Care, we have an electronic prescribing and medicines administration capability, which then links to a whole range of other innovations, such as pharmacy robots and ward-based dispensing cabinets. We have a very detailed digital delivery program spanning a number of years. But these programs of work have not just occurred overnight. We've had many years of significant digital investment, which got us into a good level of digital maturity. As a global digital exemplar fast follower, when we finished our program, we were formally accredited as a HIMSS Level 5 National Digital Leader organisation. And that gave the organisation an ambition to move further, faster. So in order to move further, we needed to understand where our gaps in our digital maturity were. So we've undertaken a detailed gap analysis, then identified many aspects that we need to bridge, most of which are linked to pharmacy-related services. Our ambition is to hit a HIMSS Level 6 target by the end of 2022, if not before. In terms of sharing and learning, North Tees and Hartlepool NHS Foundation Trust undertook an independent assessment of the effective use of our electronic patient record system and the adoption of electronic prescribing and medicines administration. The conclusion was demonstrable improvements in the elimination of errors and clinical incidents. There was further evidence of improved patient safety through the reduction of missed and/or omitted dose incidents. There was clear evidence about how we've improved time to care through reduction of process times using the new technologies available. And then finally, there was further evidence of the Trust's contribution to improving our carbon footprint. This case study was published and was then identified and became a winner of the Health Tech News Best Use of EPMA Award. But don't just take my word for it. My colleague, Dr. Jay Vasani, who's a consultant physician and our Chief Clinical Information Officer, talks about the transformation journey within the organisation being one of evolution, not revolution, and that everybody is bought into the idea that we need to digitise lots of processes, reduce our reliance on paper and improve our clinical care. But how do we align patient, practitioner, organisation and system using technologies? Well, from a patient or service user point of view, we now know that many services are available online, but not everybody can access online digital services. So we do need to reflect that into the future design of our systems and capabilities. But where we can access technology digitally, for example, ordering prescriptions from your GP or having virtual consultations in real time, they are available now. Your GP can then request orders to be dispensed at a pharmacy of choice with electronic prescribing systems messaging between the two organisations. If patients or citizens are unable to get to a pharmacy of choice, then there's also options to have your prescription delivered via a home delivery service. Long term, we may even see drones dropping your prescriptions off at your front door. In terms of patient interaction with secondary care, we can see electronic referrals coming from primary care services into secondary care. Within the secondary care service themselves, the aspects that I've already mentioned, such as electronic patient records, electronic prescribing and medicines administration, the link to both pharmacy, robots and dispensing cabinets, and the elusive closed-loop prescribing aspects that will then improve patient safety are all examples of how the practitioner and the patient can use digital systems and services to improve the care offer. We also now can see the use of interoperable shared records between all of the points of delivery through the Great North Care Record to allow real-time information to be where it's needed in order to make important clinical decisions. Last but by no means least, the ability for a patient or service user to then feed back about the quality of service that's been received through patient-recorded outcome measures and/or the friends and family test. Another example of how digital services will improve the transformation of the medicine offer. But what could digital do for medicine and pharmacy-related services? And if we just reflect on the 5 strategic ICS themes, we do need to make sure that we get the basic essentials right, the plumbing, the pipes and wires, and importantly, our security offer. How we can use technology to empower people, but at the same time, don't create a larger digital inequity gap. We need to make sure that there are hybrid offers to allow people to interact through the channels of choice. Let's use technology and expertise to create thought leadership. We may not have all of the answers ourselves, but where we can talk to experts, can we rapidly adopt ideas and opportunities collectively? We need to make sure that we connect all points of care, and citizens need to be engaged in part of that offer. We are literally limited by our imaginations, and the world of technology is moving rapidly. But there are many innovations that we can look to adopt, such as artificial intelligence, machine learning, the use of smartphones and wearables, implantables, and so on. All of these things are available now and ready for use and adoption when the time is right. Ultimately, this is about not doing the same things better, but about doing better things, and digital will enable that to happen. Thank you. That now concludes my presentation, and I'm happy to try and answer any questions.
Brilliant, Graham, thank you so much, that's excellent. We're going to be moved into breakout rooms quick, but I think we may have a few minutes to answer a couple of questions. So if I can pick up on a few things that have been coming up on the chat that you've been answering already. Do you want to say something about health inequalities? And I don't just mean populations that might have digital inequity, but also inequality within the workforce. So how do we make sure that we bring the workforce with us?
My personal view is that we need to make sure that there are the technical abilities, first of all, but also
trying to motivate people, let people understand the real benefits of digital transformation. And it's not a panacea for every problem we've got. Sometimes technology isn't the answer. But if we can't describe what we want to do and describe our plan of action, it's very difficult to deliver. And one of the reasons that technology-enabled programs fail, because it's all about the tech. This is about transforming health and care services. Just reading the chat, if we get domain experts such as chief pharmaceutical information officers to describe the problem, then the chief information officer can look at the right solution for that problem. That would be a typical response I would make.
No, that's really helpful. And how do you get the jobbing pharmacists and pharmacy technicians and other members of the pharmacy team, and doctors and nurses, I guess, how do you get them to engage with people like yourself and others, so that you're making the right decisions when it comes to your technology strategy?
First of all, it's about explaining what it is that we're trying to do, and have the clinicians share their particular frustrations, and also try to work together to describe some of the approaches. And quite often, if you try to do things in one step, you will set yourself up for fail. So I think small incremental step changes is part of the solution. Technology is changing so quickly, and quite often there might be a solution tomorrow for a problem that we have today. We can't just do this immediately, but my closing comment would be, don't let perfection be the enemy of the good.
Yeah, so that's an excellent way to end your presentation. Graham, thank you so much for speaking today and also engaging with our delegates. That's been brilliant. And people, thank you everybody for engaging on the chat. Please do continue. There's some really good conversations happening there.
So hello everyone, my name is Jane Brown and I'm the Pharmacy Dean for Health Education England for the north of England. I must admit I struggled somewhat to get started on this presentation. Whilst I love technology when it's intuitive and simple to use, I love the fact that my phone can be used as a library, an address book, a camera, and I can simply photograph travel receipts and submit them through an app and all sorts of things like that. However, I'm certainly challenged when it's not working. Whilst working from home, I've been known to shout at my laptop when something isn't happening, and I'm a regular user of the switch it off, switch it back on again school of thought. So that got me thinking about how we can take the pharmacy workforce forward in a digital world, as I'm sure I'm not the only one who struggles sometimes with technology. But I also started to think about the real purpose of being a pharmacy professional. What are we here for? And of course, we're here to support patients to get the best out of their medicines. So any presentation about taking the pharmacy workforce forward needs to think about how we take patients, carers and the public with us on this journey. And I was really pleased that Graham had included that in the ICS strategy for digital. Next slide, please. So this is a quote from a real patient, but some of you might actually recognise that she also happens to be my mum. And she has given permission for me to include her story in this presentation. She had a virtual appointment with a hospital consultant recently, which actually wasn't really virtual, it was just on the phone, which can be problematic for some people. The hospital encouraged her to sign up to a portal so she could access hospital letters and other things about her care. And I was signed up as her carer. However, when I logged into the portal recently, there was nothing there. And this was 8 weeks after her appointment. There was still not a letter telling her what the outcome of that appointment was and what the plan was. So just to talk about that portal, I struggled to navigate around the website and it really wasn't easy to use. So if I struggled with it, how do you expect an 80-year-old to manage that? And I'm not saying that she can't use technology at all. She's worked out Zoom and she has coffee mornings and virtual bell ringing during the pandemic. She can manage Duolingo and is trying to teach herself French or improve her skills. And she's also competent with WhatsApp to stay in contact with her grandchildren. She can send emails, but she struggles a little bit with setting up folders. And because she doesn't print things often, you know, I do have to remind her what the little icons mean. But I think if I'm really, really honest, I think one of the main issues is that she's just not that interested in technology. And so that brings me on to the next slide. So this is a photo of my dad, who's also known as G3TVU. He loved technology. He was an electronics engineer by background, and whilst radio communications is analog rather than digital, it was something he was extremely passionate about. And so he was the one who sorted out everything technical, whether it was online banking, online shopping, email, and other things that we would all find quite basic these days. Growing up, it was absolutely great having such a techie dad, because we had one of the first video games to play through the television, which was a very simple device playing tennis. And anyone who's sort of a current pre-reg pharmacist will have no idea what I'm talking to, because things have changed amazingly with animation, avatars and virtual reality. And what we thought was really state of the art probably was sort of all that time ago, but is nothing now. We lost my dad about 18 months ago, and so that left a huge gap in my mum's capabilities. She has to do it all herself now. Next slide, please. I think when we talk about digital now, what we're really talking about is technology. And Graham talked really well through some of these pharmacy things that are on the slide here. But it has been evolving over many years. A very long time ago, whilst I was studying for my postgrad clinical diploma, I visited a hospital in the region that I'm assuming had one of the first electronic prescribing systems. Again, that was probably state of the art in those days. But amazingly, when I went to work there 20 years later, they were still using the same system. So it was interesting to hear about what Graham said about how technology sort of goes out of date within weeks and months now. But, you know, 20 years on, it had upgrades, but it certainly wasn't, you know, an easy to use system. And I think the thing I struggled with was there were only 3 prescription items on each screen. And so I had to go through multiple screens to see a patient's full medicines regimen, which, as we know now, can include 20 plus medicines. We also need to recognise that electronic prescribing may reduce some medication errors, but it also brings in different types of medication errors, such as picking the wrong medicine from a list of similar sounding medicines. What I'd really like for it to look like is like an ebook, so I can flick through the pages and see the whole list of medicines at one time. We've also brought in robots to make the dispensing and stock control systems more efficient and possibly more accurate. And this is absolutely great, but getting called in as the on-call pharmacist at 3 in the morning, I was a bit more of a grab and run girl. And there was nothing more frustrating than having to log onto the computer system, fire up the robot and issue it when I could be back in bed within no time. I guess now with the advances in technology, on-call pharmacists can probably issue medicines out of hours from home if they have the kit and the technology. There's a whole host of other areas where technology comes into pharmacy services. So electronic transfer of information about medicines to reduce medication errors, because we know that interfaces of care have a particular problem for creating medication errors. And also electronic records that patients can access anywhere in the world, which are ideal if you're on holiday and need to access healthcare. We have decision support tools to help healthcare professionals support patients to decide what medicines are best for them. And of course, because I work for HEE, we have simulation or technology enhanced learning that enables trainees to practice before they are let loose on real patients. Next slide, please. So lots of digital activity has been accelerated by the pandemic, and I'm really proud of the way that our schools of pharmacy and pharmacy technician colleges quickly reacted to the pandemic and the national lockdown and moved their teaching online. Consultations have moved from face-to-face to either telephone or video, but again, that brings its own challenges if you can't see the patient in front of you. I no longer have to travel far and wide for meetings and can attend them from the comfort of my own home. And this has surely had a positive impact on the environment. And today we're having a virtual conference. We've also delivered team away days to ensure that the whole School of Pharmacy and Medicines Optimisation team stay connected with team members, particularly for those who've been recruited during the pandemic and we've never actually met face to face. Working from home has removed commutes, but there can be an adverse effect of this in that you feel like you're always at work. And also those in the teams who are parents have also been trying to homeschool their children alongside working from home. So that's brought its own challenges. Next slide, please. So the aims of digital healthcare are to provide digital services and tools to give people more control over their own health and the care that they receive from the NHS. But it's also there to give health and care staff the technology they need to help them complete administrative tasks more quickly and therefore freeing up their time to spend with patients. Next slide, please. So these are fantastic aims, but we also need to think about some of the challenges healthcare workers and patients, carers and the public might come across. So do people actually have access to the IT kit or clinical systems? So do they even have a laptop? Can they access the system remotely? What's their Wi-Fi like? Can it handle the data required? And certainly that was something I struggled with, and my team's access during the start of the pandemic before I upgraded it. And what about access to online resources as well? Do we know whether healthcare professionals and the public use trusted resources, or do they just go and Google it and take their chances with what comes up in a search? And some systems, as we know, are very clunky and frustrating to use. We also have to change the way we practice, whether that's consulting with patients or teaching. You need a different skill set. And especially in education, it's easy to have a group of 30 to 40 students in a room working in small groups because you can easily oversee them and hover and check what they're up to. But how do you do that in a virtual breakout room? Does that cost more because we need to have more educators as well? And I think the big thing we need to think about is the loss of personal connections. A friend once told me how she wished her father's medicines would be aligned so that he only needed to go to the pharmacy once a month. But I reminded her that that pharmacy was part of his social network and the staff there would talk to him and actually they would notice if he didn't turn up one week. We also need to think about digital literacy and capability. Next slide, please. So digital literacy, they're those capabilities that fit someone for living, working, learning, participating and thriving in a digital society. Next page, please. And I think in this context, we really need to think about health and care workers, but also the people that we look after, that we care for. So the patients, the carers, the public, our general citizens. Next slide, please. So as an educationalist, I thought about this using an educational model, and the one that's up here is the conscious competence model. And I was reminded of this at a family gathering recently. My niece took my phone and she quickly changed the settings so that she could transfer a photo to me. She was showing unconscious competence. She just did it, and really, really quickly. But we need to think about how we can support our colleagues and the patients that we serve, and we can only do that by stepping back into the conscious competence mode so that you can unpick the way we do things and teach that to others. And it's the same with driving a car. After many years, you just do this. You can't remember how you got from A to B. But I bet there was a lot of mirror signal manoeuvre in there that you'll have forgotten about. And so you've been moving into the unconscious competence zone. But think back to when you were starting to learn to drive and how difficult it actually was. So we need to apply this and think about what digital capabilities our health and care staff so that they can also support our populations with this as well. Next slide, please. So HE has published a Health and Care Digital Capabilities Framework. There are 6 parts to this, and I've added the link onto the slide at the bottom. The framework outlines the generic capabilities that support individual motivation and development. It's meant to be an easy, accessible way for staff working in health and care to engage and self-assess their own levels of digital literacy against the framework. You can use it for self-assessment, to identify your own learning and development needs, to inform personal and professional development plans, and to guide formal, informal, directed and self-directed learning. And you can also use it to evaluate your own progress and performance as well. So I would suggest that you go and have a look at that and try and assess what your own needs are. Next slide, please. And of course, CPPE has got some specific e-learning for pharmacy professionals. The learning outcomes are on the slide here, so I'll just give you a second to read through them. And the link to the learning programme is at the bottom as well. But this would be a perfect introduction for us all to consider completing, and it will only take, I think it's a couple of hours. Sorry, I haven't checked that, but I think it's a couple of hours to do. Next slide, please. So I just wanted to finish off by saying that Health Education England is working towards being a digital first organisation, but that certainly doesn't mean that we'll be digital only. So we all need to be competent and confident in a digital world, but we also need to think about when digital is and isn't appropriate, and make sure that any digital interventions we put in place, we make them user friendly, and we make sure that people have the resources to use them, and they also know how to use them. And the final message from me really is that this is fantastic. We can really, really take this agenda forward, but it's definitely about people and not computers.
So the emphasis is on evaluation. If you are interested in research with big data, there was a really good online event a couple of weeks ago with the Medical Research Council, and I'll circulate a link to the recordings from that event in a workshop supplement that you'll get after the event today. So for those of you who don't know me, my name is Gemma Donovan, and I'm a pharmacist academic practitioner. I spend part of my time at Sunderland Clinical Commissioning Group, and I'm also a senior lecturer at the University of Sunderland. And I've also got helping with me today, Adam Rathbone. Do you want to introduce yourself?
Yeah, so I'm a lecturer at the School of Pharmacy at Newcastle University, and I'm going to just be helping Gemma with the presentation.
So yeah, so we've kind of pulled it together, me, Adam and Anna, who can't join us for this session, to kind of get a feel for what we thought might be most relevant for the people who are likely to be in the sessions this afternoon. So without further ado, let's bash on. So this is, I should stress, this is just an introduction. Neither me nor Adam, I don't think, are going to be claimed to be experts in this particular area, but it's a basic kind of introduction based on our experiences using this type of data for research and evaluation. So we're going to be having a look at the different types of data sources that could be helpful for medicines related research. We're going to be looking at examples of how this data can be optimized to appropriately answer research questions, and some things to think about when working with routinely collected healthcare data. We're going to start with a workshop exercise. So try to make this interactive. So you can either grab a piece of paper and a pen, or if you're feeling more digitally inclined, I have popped in the chat a link to download a PowerPoint slide that you could also use for this exercise. We're going to be returning to it throughout the workshop, so it would be good if you could actually do it, because we'll be returning to it. So once you have got your piece of paper and your pen, I want you to divide it in half with a line. And on the left-hand side of the bit of paper, I want you to write the types of things that you are interested in terms of research, evaluation, or kind of any innovation projects. This could be things that you're currently working in, or it could be things that you might want to work in the future. 5 to 10 words, don't think too much about it, just what kind of things are you interested in? On the right-hand side of the bit of paper, I would like you to write down as many routinely collected healthcare data sets that you think you have access to at the moment. So write all the ones that you can think of on the right-hand side. And then I would like you to have a go at connecting your research or evaluation or innovation interests with the routinely collected data sets that you think you have access to. So I'm going to give you 2 minutes to have a go at doing that exercise and getting some stuff down on either physical paper or on your digital slide. Okay, so hopefully everybody's had a go at that. So before we move on, make sure that you keep it close, that you save it, that you do something with it so that you can return to it later in the workshop. Okay, so let's start by finding out what interesting data sets you managed to identify. So if you could pop some examples of the things that you identified in that last session in the chat, that'd be great. So I can figure out which ones I've missed out from the next slide. I don't think I know what model hospital is, Ewan, actually.
I'll show you, Gemma.
Okay.
It's not a pharmacy specific thing. It's kind of whole health system. It started off as just hospital stuff. It's now broadened beyond that to whole health system stuff. I'll show you.
Okay, great. Looks like there might be a few people from primary care based on the suggestions so far. Oh, thanks, Adam. Kath, yeah, I haven't included any educational data sets, unfortunately. Bob caught me out in the last workshop as well. Okay, great. Okay, feel free to keep popping them in. But yeah, we're gonna move on. So what we did was we got our heads together and we thought of the ones that we could think of. So this one might be one that you didn't necessarily think about, but obviously there's a lot of clinician groups that have chat channels, and obviously they can potentially be a source of data that you could use. We've also got incident reporting systems. Obviously data for that is available nationally via NRLS, but you also might have access to local data through systems like Datix or SIRMS. Records of meetings, so minutes of what has occurred in those meetings. Quite a few of you have already mentioned prescribing data that can be used, and this could be obviously from primary care, so a few of you mentioned Prescript and open prescribing, but also you might be able to directly extract data from your own, for example, electronic prescribing systems or from GP records. Obviously, we've also got service delivery bits of software, so things like farm outcomes that we can use to track service delivery in community pharmacies, for example. So that could be a data set you might have access to. Direct extraction from medical records, so for example, EMIS searches. There's also some national data sets, questionnaires, which are patient generated, which are available that you can use as well. And there are also some examples of coordinated audits for specific clinical areas as well, where actually the same audit is used across a broader geography or even nationally, and that data set is often available nationally as well. And HES statistics, so hospital episode statistics, which demonstrate data on kind of healthcare utilization as well. Okay, so next question, what are you going to do with all of this quantitative data that you're kind of getting hold of potentially? We're going to have a go at doing a poll, so you can either go to slido.com. If you've got a mobile phone to hand, you can scan the QR code, or you can obviously open another screen if you're working on a computer and split your screen. If you pop in that reference number there, I would like to invite you to tell me which of these numerical data analysis techniques you are most familiar with. So if you could have a go at doing that, I'll just give you a minute to access that. Okay, great. So the point of the poll was to try and give you a bit of confidence that actually some of this quantitative analysis isn't particularly rocket science. So things like calculating an average or a percentage, or even creating a line graph or a bar chart can give you some of the analytical information that you need to be able to conduct some kind of evaluation or research. Using Excel formulas, I will grant you, is a bit of an obscure option, because obviously they could be more complicated or kind of less complicated. But the point is that using software like Excel can actually be quite a powerful tool for lots of different types of research and evaluation. So the reason that we want to place this emphasis on description is it's often the most useful form of analysis, especially when you're thinking about evaluation. And actually, some of the more fancy inferential statistics might actually not be appropriate on the data set that you've got. And this could be because your data set may be quite small, so actually you're unlikely to detect anything anyway. And actually, it can still help you understand quite a bit of what's happening in your organization. If you want to increase the robustness of your kind of descriptive analysis, then it might actually be better to triangulate your findings by using an alternative data source or looking at it from a different perspective, which will increase your robustness of what you think you're finding, but without actually necessarily increasing the complexity of the statistics that you're kind of using. If you do want to do the snazzy statistical techniques, then that's obviously still an option for you. But I would always suggest that you get some support or advice. And actually, you still need to be doing the descriptive stuff first, because you still need to know what you're looking for in terms of those inferential statistics anyway. So a couple of the data sets that have already been mentioned, a few of them are kind of more raw, what I've called raw data, and some of them are kind of pre-analyzed. So these are things like the prescribing indicators that are already generated on websites such as Open Prescribing. There are some benefits to using pre-analyzed data. So for example, it's usually been anonymized, so it's usually open access, very accessible. And also it potentially could be pre-integrated with other bits of data. So for example, combining prescribing data with hospital admission data, for example. So that work kind of has already been done for you. And that makes the analysis process much more efficient, especially if you're kind of time poor and don't necessarily have the time to be doing lots of analysis. The raw data is likely to be identifiable. So you're going to have to think about the confidentiality considerations of using that data. But it does allow you to be a bit more bespoke. You can choose potentially how you link those individual patient data points with other forms of data that you might be interested in looking at connections between. But it will also potentially likely require further approvals as well. So that's just some things to think about with the quantitative data sets. So this is an example of a kind of interim evaluation analysis that I've conducted quite recently for Sunderland CCG, looking at opioid reductions. So this is looking at total prescribed morphine equivalent. So for me to calculate this manually by looking at the number of items for different types of opioids and then trying to figure out how that converts, etc., would actually be very time consuming. Whereas Open Prescribing currently provides or did provide an indicator for this already. So they've already done all of that conversion for me. There's also a quality assurance process there. So I can be confident the data that I'm downloading is kind of accurate. And then I just need to focus on what I want out of the data to answer my research question. So in this case, whether the initiatives that we're using in Sunderland to try and reduce opioid prescribing seem to be working. So in this particular graph, it's just a line graph, relatively simple. I've just got time along the bottom axis, and I've basically tracked this total prescribed morphine equivalent over time. And I've done it per 1,000 patients so that I can compare the national figures to those in Sunderland. So you can see that the orange line is the national figure, which is decreasing, but looks relatively stable. And the top line is a good distance away where we are in Sunderland. And all I've done is overlaid this with the things that we have done to see if they seem to potentially be having an effect. And what you can see is for the things that I've identified and the time points that we think we've done things, you can start to see a bit of a decline. And that is fine. It's basically telling us what we think might be happening in Sunderland as a result of the initiatives that we've taken. And it doesn't need to go much further than this for evaluation, because what we can do is we continue to track it over time and just kind of see what happens. So I'm hoping that this demonstrates that using quantitative data and just doing a descriptive analysis can actually provide you with a lot of information to help you answer some of those evaluation questions. So I'm now going to hand over to Adam for the qualitative portion.
So similarly to what Gemma did with her Slido, if you could use your phone or split screen and go to slido.com and enter the code, and then try and answer these questions that are linked to what you might do as part of a qualitative project, where you might look at documents and try and work out what the context of the document was, try and figure out links between what people have said within the documents, reflect on what what's been written and why things have been written or said the way that they've been said, and identify similarities and differences in what people have said within any given document. So this could be documents like meeting minutes, it might be documents like prescriptions, it might be policy documents, standard operating procedures, it could be a whole range of different documents, error reports, data reports. Okay, so it looks like there's people would kind of be able to do quite a lot of those things, and then that last one at the end about spotting the differences and similarities and differences, maybe not so much. Thinking what people have said to what they mean, maybe not so much, but most people feel pretty confident to be able to interpret what people have said or what's been written and what it means. Super. So Gemma, if you want to go on to the next slide, please. So qualitative analysis is a way that we can explore, conceptualize and understand new phenomenon or parts of practice that maybe we haven't looked at before, or maybe aren't associated with kind of key performance indicators or data that can easily be kind of categorized in a discrete way in like a chart or a bar graph or something like that. It's particularly good for looking at new roles or new services, as well as patient or professional experiences, because often what people experience and how they experience it can't be put into a little box. And if it's a new service or a new role, then those boxes might not have been created yet. So you might do a piece of qualitative work to come up with those key performance indicators or those key bits of data that you'll want to collect. It's important to acknowledge, though, that within qualitative approaches to projects, the researcher is an important part of that. So some pharmacists might naturally think, oh, that's a bias. It's just opinions. It's just feedback. It's not really important. It's not valuable data. But actually, within qualitative research, we would advocate that actually a pharmacist doing qualitative research about medicines makes that project more valid, because pharmacists have expertise about medicines, so they would be able to see meanings and inferences and understand contexts about medicines from data that maybe already exists that isn't being analysed. You can be quite pragmatic, as Gemma said. You can be with quantitative analysis. You can do descriptive work that is quite simple and just shows you kind of facilitators and barriers. It tells you who's speaking about what and how they're speaking about it, or it can tell you who is doing what and how they're doing it. But you can also do more theoretical framed research or evaluation that lets you understand phenomena in a more theoretical way. And if you were going to do that, then we'd suggest you maybe get some support from an academic to try and help you get around the theories of that type of thing. Do you want to go on the next slide, please, Gemma? So these two examples of where we've done a piece of qualitative research and evaluation that helped us explore a new phenomenon that was using technology that had data associated with it, but hadn't actually been tapped and hadn't actually been utilised. So people often didn't speak about it. So for example, many of us use WhatsApp in our everyday work. We contact colleagues on it, we deal with queries on it, we might ask for information on WhatsApp from colleagues. But actually from a policy and governance perspective, the guidelines are often quite restrictive. They say you shouldn't use social media, you shouldn't use WhatsApp, you shouldn't use personal devices to contact each other. So we did this project to look at what was happening on WhatsApp when pharmacists were working out of hours. What were they saying to each other? Who was saying it? And how were they saying it? It was quite a good study because it happened just at the time of the WannaCry virus. So the conventional tools of communication within NHS organisations were shut down. And as we've heard from somebody else at the conference who said that hospitals kind of shut their communications between each other and even within departments. But WhatsApp was still functioning, and so this project really captured how WhatsApp could be a really useful tool for the NHS when things like WannaCry happen. So although it was a qualitative project, and many people think, oh, that's namby-pamby, softly, doesn't mean anything, it actually has had a really important and impactful role in changing the way policymakers and practitioners think about using social media and messaging platforms and communication platforms within the NHS, and looking at how information governance policies can be adopted to include that. And in that project, we just looked at what people said on WhatsApp, just looked at a string of messages, read them over and over again, picked out who was saying what, how they were saying it, what the relationships meant, and then we published it. Other work that I've done with my colleague, Dr. Lindsay from Newcastle, is look at other ways that we can use existing textual data that's collected in the NHS. So one of these studies looked at Datix reports before and after an electronic prescribing medicines administration system was implemented. And all of the data that had been collected by the EPMA people said that errors had gone down. But our qualitative analysis of Datix helped us identify that there were some members of the team that really hadn't experienced a reduction in errors. They'd actually experienced an increase in errors because of particular types of the way they worked or the type of person they were, that meant that the conventional way of collecting that data hadn't picked up that they'd seen an increase in their errors. So by doing a qualitative analysis of that Datix data, we were able to pick up that there were still some issues with errors relating to medicines for particular populations within the NHS. We were also able to, in that project, report a study that used meeting minutes from formulary committees, where we saw who was speaking about medicines and what they were saying, and how that informed decision-making about whether products were approved or not. That meant that when it came to trying to make interventions to change prescribing habits, to change formularies, we know exactly who to contact and exactly who to target our communications to change the kind of decision-making process around medicines. So although pharmacists typically don't use qualitative research, it doesn't tell us which drug is better than the other drug, the fact that these two papers have been published and that they're having an impact out there in the UK and overseas shows, hopefully, that this type of work is valuable and can have an impact and can help improve service design and delivery.
Thanks, Adam.
Thanks, Gemma.
Okay, so we've now hopefully given you some additional ideas. So I'd like you to get that piece of paper back out or reopen that file and have a think. Could you add some more routinely collected data sets to that right-hand side of the page? And or could you potentially draw more lines either to those new data sets, or could you actually add some new lines between the data sets that you already had on there? Based on thinking about things a little bit differently. So I'm going to give you a minute to return to that diagram and see if you can update it. Okay, so hopefully you're starting to get a few more ideas about what you could do. So once you've got these kind of things in mind, you then need to think about formulating some research questions about what kinds of things you might want to do with this potential routinely collected healthcare data. So what I would encourage you to do is have a think about what matters to who and why do they care. So think about potentially the perspectives of the payers, the people who buy your services, the commissioners, maybe your patients or service users and what they might be interested to know. Maybe you have some regulatory or governance requirements. Maybe that's overseen by someone else. Is there something that you know you should be doing that might be worth exploring? Or maybe have a think about other stakeholders or interested parties. We're increasingly all potentially going to be working closer together across healthcare boundaries. Are there other people in actually different organisations who might actually be interested or might want to work with you on answering particular research kind of questions? And I tend to take quite a collaborative, well, all researchers are collaborative, so I don't know why I'm saying it's just me, but a collaborative approach is best when writing research questions and designing research studies. The more people that you have involved with different perspectives and different ideas, usually the better your research questions end up being. So have a think about whether actually some of these people who you might actually be the customers of the research or the evaluation, whether they could actually be collaborators on the project. And I've used the Finer Maps acronym there as some suggested words to think about when you're developing those research questions. So in addition to thinking about whether what you might want to find out is interesting or novel, Also have a think about whether it's actually feasible, whether it's potentially ethical to do it, whether it feels relevant to your organisation or your day job, whether it's manageable, appropriate, and what might be the value of it to your organisation. And importantly, all research is kind of systematic. Now, for some of you who might be relatively new to research and value, some of these things are difficult to judge, absolutely, because things like feasibility, you kind of learn that as you go and as you do research projects. But that's why I would always suggest that you get help to help you plan out some of these research questions and the methods and things that you would ultimately use. And when you're writing a research question, it's important to think about what will the data and what will the research question help you to then know at the end of it. So will you be able to potentially identify a potential problem or phenomenon that you think exists, but you're not quite sure? Or will it help you better describe or understand a particular issue that you know is going on? Will it help you to deconstruct something to see how something works, not just whether it works or not? Or will it potentially help you identify relationships between things? Could you potentially compare outcomes between different conditions? Or you potentially might want to detect causality between something happening and what the impacts of that ultimately are. So lots of things that you can potentially incorporate into your research questions using routinely collected data. So let's think about things that you might want to consider. The first thing that I would always say is that you need to start with the research question, not with the data. You need to make sure that if you're going to be putting in time and effort and resources into doing a bit of research or evaluation, that it is actually being driven by some kind of important or valuable research question. And then at that point, then you need to go back to the data and see whether the data that you have available will help you answer that research question or not. The chances are that there are going to be limits to the extent to which that data will be able to answer that research question. And writing research questions is very much an iterative process. You start with drafts, you speak to people, you discuss things, you think about what's feasible, and then you go back and you refine it. And it's no different when using routinely collected data. So although the data that you have available or what you don't have available may inform your research question, it should be the research question that is driving the process, not the other way around. So I don't know if we've got enough time or not, actually. I'm going to suggest this is a homework exercise for you, I think, to save me getting into trouble. So for the bit of paper that you've been working on, or the PowerPoint slide or whatever, those lines that you have drawn between your potential research interests and the data that you think you have available, they are all brilliant fodder for potential research questions. And actually, one of those lines potentially could be several different research questions. So what I would encourage you to do after today is to go back and have a go at phrasing some research questions that link those lines between your interests and the data that you have access to. So some more things to think about. Prioritize suitability of using that data to answer your research question over just its blatant availability. So you don't want to just be starting with your data set and saying, what can I answer? Start with what is suitable to answer the questions I'm actually interested in. And for both qualitative and quantitative data, it's important to consider the context of the data and why it was generated. So for example, prescribing data, for example, although we call it prescribing data, it's actually dispensing data. Obviously, nothing can be dispensed without it being prescribed, but that isn't actually the purpose for which it was generated. It was generated to pay pharmacies to supply those medicines on behalf of the NHS. And when we're looking at it as a prescribing data source, then that is a secondary use of it. And that has some implications that sometimes we kind of need to think about. Similarly, for the qualitative stuff, why were these documents generated and how does that affect your interpretation of them? And for any type of data that's routinely collected, what was the timing of it? When was it collected? How frequently was it collected? What other things were happening around the time of its generation that might affect how you interpret it for the purposes of research or evaluation? Of course, you don't have to use just routinely collected data. You can use other data sources to complement it. So for example, in a CRP evaluation I'm working on at the minute, we're using routinely collected data in relation to the CRP test uses, but actually we've also used that data to identify.
Gemma, I think we might have lost you. She's not coming back, I'll take over. So thinking about what you might want to think about when you are putting together your own project that's either using quantitative or qualitative data would be, can you collect the data that's already there? So or to complement what's already there. So if you already have a whole bunch of surveys or KPI data, can you collect a little bit more data that would just make that data a bit more meaningful? So for example, if you know that your pharmacists do 10 consultations a day, could you do a little bit of data collection where you do some observations and you see what type of patients they see in that period where they're working on the wards? Other things that you might want to think about, what the impact would be if you use that data just on its own, and what messages you could actually convey from it. So are you using it out of context? So an example for this might be that the minutes of a meeting get put together and you interpret those, or you use qualitative analysis to interpret those minutes and come up with, an identification that the chief exec who's in the meeting doesn't listen to pharmacists or something like that. Sure, that wouldn't be the case, but something like that. Actually, the context of those minutes is for recording of an event. It's not really for research. It's not really looking to find out what the chief exec thinks about pharmacists. So always remembering that the context of any data is really important when you come to analysing it, either qualitatively or quantitatively, so that you don't misinterpret what's being said, or you don't use the data out of context.
Just to say that there'll be a workshop supplement that comes out after this, so if you want any links to data that's available and to Adam's papers, and also the evaluation, the opioid stuff, that will all be available on there for you guys to access. So we hope you find that helpful.
I am here to talk to you guys today basically about my journey through mental health pharmacy. So I'm Laura, and like I say, I'm here to tell you why I love working in mental health and why you should too. So when it comes to doing PowerPoint slides, I've got a bit of a love-hate relationship with them, and I hate feeling like I'm putting loads and loads of text on a screen. So given the fact that today is more about me telling a story, I'm going to take you through my journey in mental health pharmacy through a series of memes and GIFs. I'm going to start a little bit back to front, but hopefully all will become clear as we get further through my story. But just to give you a brief insight, I've been working in mental health services for CNTW for almost exactly 9 years now. And at the moment, I work in a community mental health team as an advanced pharmacist practitioner supporting older adults with a range of mental health problems, from depression and psychosis right through to people with severe dementia. So more on that later. But before that, let me put a couple of things about mental health in context for you. So mental illnesses are common, long-lasting, and more impactful than a lot of other health conditions. It's the second largest source of burden of disease in England, according to Public Health England. 1 in 4 people experience mental health issues each year. Total cost of mental ill health in England is estimated at about £105 billion every year, and up to 75% of people with mental illness receive no treatment at all. So 21st century improvements in early intervention and treatment methods and newer medicines mean better recovery rates, and recovery is much more likely if illnesses like psychotic episodes and schizophrenia are treated early. It's an area where I feel pharmacy teams can provide so much support and benefits to patients. Unfortunately, however, there's still so much stigma and outdated stereotypes associated with mental health, especially for those people requiring inpatient mental health care and treatment. I'm sure you know all the ones I'm talking about. Probably looks something a bit like this. So what we can see here is how mental illness is often portrayed in film and TV dramas, the offensive costumes that all too often get trotted out at Halloween of people in straitjackets, how the media report on people with mental health problems. You can see the language in the reports there, using words like bonkers, locked up, and the word mental being weaponized and used incongruently in order to invoke negative connotations. Even down to the way suicide is reported in the media. People are still reported as having committed suicide, despite this having been decriminalised in England since 1961. And actually, of note, it was never even a crime in Scotland. And I think I've got a story that encapsulates this no more better than when I had some undergraduate students shadow me a few years ago. After I'd spoken to them generally about mental health and what I did, I explained that we were going to chat to one of my patients who'd very kindly agreed to speak with them and tell them about his experience of living with bipolar disorder. One was thrilled and really, really keen to meet this chap. The other one, however, when I explained this to him, the colour drained from his face. He asked about the security arrangements on the ward and what protection we would have. And, I calmly explained to him that this man wasn't dangerous, didn't present any risk to us, although I'm really not sure I reassured him that much. Nonetheless, he did agree to come with us, and when he entered the room, he wouldn't sit down and stood with his back to the wall beside the door. Now, I'm telling this in a humorous way now because looking back, it was funny for me to see him acting like that when I knew there was nothing to be worried about. It does, however, highlight the stereotypes of people receiving inpatient mental health treatment, and it demonstrates the stigma that people with enduring mental health problems still face to this day. Now, I'm not innocent in this. I had these thoughts before I had any insight into working in mental health too. But fortunately, however, I spent an all too short period working with professionals who were able to re-educate me. So let me take you all the way back to 2009, where this journey begins. So, fresh out of university and joining the world of full-time work, I think this adequately describes not only how I felt as a pre-reg, but also newly qualified when we get that far. I was fortunate enough to get the hospital pre-reg I wanted, and I was thrilled to see in my packed schedule all the different clinical specialities I was going to experience over the coming year, except one, mental health. Now, looking back on this, I now know it was because I knew so little about it, and it was really fear of the unknown. My undergrad at university had really consisted of sort of a problem-based learning case on a patient with depression and a very, very short overview on psychosis. And I'm very sure that a lot has changed over the intervening years, and it's very different now. Compounding that, of course, I had all these stereotypes that I've just described that are associated with mental health. And so with a degree of trepidation, I started here. This is what used to be the Royal Edinburgh Hospital. It's having a bit of a fancy redesign as we speak, so it won't look like this for much longer. But on an interesting side note, it seems there must have been a bit of a blueprint for the design of psychiatric hospitals back in the day, as this one actually doesn't look that dissimilar to the hospital that we have in Newcastle as part of our trust. So as I said, I rocked up here with a bit of trepidation. I really needn't have though, because those 4 weeks actually turned out to be the best of my entire pre-reg year. And that was demonstrated no more so than the week I spent on the forensic unit. And for anyone who doesn't know, when we talk about forensic in relation to mental health, this is patients who are having care and treatment for mental illness in the context of their involvement with the criminal justice system. So in our forensic unit here at the Royal Edinburgh Hospital, it's a medium secure unit, the Orchard Clinic. I spent time with one pharmacist who had such a passion for working in mental health. I didn't know it at the time, but it ultimately led to a big turning point in my career. And what I was able to see here was the breadth of professionals involved in individual patients' care and treatment. I was really, really blown away by how closely the pharmacists worked with the entire MDT, but in particular the occupational therapists. But the whole experience was a really true insight into effective collaborative MDT working. And it was a big change. The rotation that I'd been on immediately before my mental health placement was on a GI unit where, let's just say, some of the senior medics were a bit sceptical of the pharmacy team, and some felt that our expertise weren't necessarily required. And so seeing how much it was welcomed here was a real breath of fresh air. Now, I need to make an important disclaimer here. It has been more than a decade since I worked in an acute hospital, and I understand that this might not be representative of all GI units, so I hope nobody takes any offence to that. So we fast forward 3 years now. I'm qualified. I've finally got the hang of juggling bleeps, dealing with discharge dosettes that were needed yesterday for patient transport that for some inexplicable reason was booked before the medicines were on the ward. And I've even managed to make friends with the scary charge nurse on the surgical admissions unit. But I was ready for my next challenge. I just never realised that it would involve moving into mental health, nor a move down south. However, it did, and I joined the team at CNTW in 2012. And very quickly, I became this girl. This gift says it all. I honestly thought at some points I really had bitten off more than I could chew. I was struck by how different it was to the experience I had had as a pharmacist up to that point. The first thing that really struck me was the change in pace. I was so used to getting lunch around 3 p.m. on a good day, and I would never ever be able to manage to see all of the new admissions on any of my wards because the turnover is just so rapid. Not so here. My phone wasn't ringing off the hook. I got to review the drug charts for every patient every day if I needed to. I even got time to sit down and speak to patients on multiple occasions if I needed to. Discharges were all planned. It was a revelation. Though it was a big adjustment at first, that change in pace made me feel like I wasn't doing enough until I realised that I finally had a chance to do a lot of the things I'd always wanted to do as a clinical pharmacist, but I'd never really had the opportunity to do because of time pressures. So I had, like I say, more time with my patients. I had more scope for optimising people's medicines, and there was that real drive toward better collaborative working. One other thing that really did stick in my head was how the medical staff sought out the pharmacy team. We were really, really welcomed into the ward rounds. We were proactively contacted for advice rather than us having to go in and speak to the team about something that we needed to look at. And all of that really made me enthusiastic about wanting to get involved with the teams and the patients I supported. I also got to experience all of the different aspects of mental health care, and it's a bit of a running joke that I think I've worked on most wards across the trust. So I've worked on wards for adults with mental health problems, adults and children with learning disabilities, acute admissions wards, rehab units, assertive outreach teams for patients who are difficult to engage, crisis teams supporting those who are the most acutely unwell as an alternative to being admitted to hospital. I've worked on wards for people with criminal backgrounds, for older people with dementia, really, really broad range of specialities. And I guess what I hope to convey to all of you is that even within a speciality like mental health, there's such breadth and so much variety for pharmacists and technicians that working in mental health doesn't have to pigeonhole you into a specific area because there's so many opportunities within it. Now, don't get me wrong, learning a new clinical area is hard. Anyone who's moved from one area to another, it's starting at the bottom again, and you know it's hard in the beginning. I felt completely out of my depth for what felt like a long time, and it's laughable now considering what my job is, but for the first 18 months of working on a dementia care ward, I kept everything crossed that what I was doing was right. I'd never had any patients with such severe dementia and such complex needs before that I didn't feel like I could add anything meaningful to their care and treatment. I eventually confided this in the very nice and supportive consultant psychiatrist on the ward, and he very kindly took me under his wing, and I still credit him to this day with teaching me the majority of what I know about old age psychiatry. So thinking about all these things I've said about working in mental health, I don't want you just to take my word for it. as part of my preparations for doing this session today, I took the opportunity to speak to some of my colleagues on their opinion about working in mental health. So I spoke to some of the most junior in our department, right up to some of our lead pharmacists. And here are some of the things that they had to say. So every day is different to the last. You are highly valued and respected by the MDT, and you have the potential to improve the quality of life for a lot of people. It's very much a patient-facing role and is incredibly rewarding. Mental health is one of the most rewarding specialities to work in. Supporting patients at their most vulnerable and through their recovery is by far the best part of the job. It's incredible to see how the pharmacist is a valued part of the multidisciplinary team and how our expertise influences patient care and treatment. I urge everyone to gain experience in mental health. The skills you develop are second to none, and there are abundant opportunities to develop your skills and advance your career. Moving from medicine to psychiatry was challenging, but hugely enjoyable. Pharmacists don't routinely associate themselves with using a holistic whole person approach, but it really enhances the appreciation and understanding of health in general. Mental illness could affect any of us at any time, so it's comforting to be part of a team supporting those in need. Some of the most satisfying and privileged moments in my long career have been seeing people recover from mental health issues. So for me, there were a couple of themes that really came out of the thoughts that my colleagues sent to me. That theme about being rewarding and seeing the people who come onto your caseloads or are admitted to hospital who are really acutely unwell when you first see them, and actually getting to see them get better after their time spent in our services. It really is rewarding. But also how valued the profession is as part of the wider MDT. And that's not just related to the pharmacy team. I can honestly say that's the case for all the different specialities that work into providing mental health care and treatment for clients. So I eventually got to the point where I felt like this guy. I've got the knowledge. I'm confident most of the time in what I'm doing. For me, however, that's usually a good indicator that I'm ready for a new challenge. And boy, did I get it. Not only did I take on the independent prescribing course, but I was fortunate enough to become a senior pharmacist in 2016. And I'm told that during that interview, my passion for working with older adults was apparently very clear. So apparent during my interview that I was actually given the opportunity to make this my speciality. And it's all because I talked about it. I had a leadership team who were open-minded and prepared to support me in doing something that I was passionate about and help me to drive that forward. So since getting that job, I've done a few different things in relation to old age psychiatry. I've led the inpatient service delivered to older adult wards in a couple of different localities before I moved into community services in 2018. I started working in the Northumberland Memory Service, which assesses people with possible cognitive impairment and in some cases gives people a diagnosis of dementia. And that was to start people on memory drugs following that diagnosis. But actually our nurse manager was kind of forward thinking, and she said to me, Laura, I feel like your skills would be put to better use by working with people who are on more complex medication regimes, who have more complex needs, and those patients are usually cared for through our community treatment team pathway, which is just a plainer name for a community mental health team. So in 2019, I moved into the community treatment team to begin developing a brand new role. So before I tell you a bit more about that in depth, just a little note about community mental health services. So this is our iceberg of patients who are under the care of secondary mental health services. So what you see at the top is the people who are treated in inpatient services. So although these inpatients may be in the most urgent need of treatment, the largest majority of patients under the care of secondary mental health services actually reside in the community. So that's all those people that are below the water surface. A colleague used this analogy of an iceberg in the past, and actually I think it's a really good illustration as to what that means. So back to my role with the community treatment team. No job like this had ever existed before in the older adults pathway. We do have other community team pharmacists who've worked in other different pathways, but once you get involved in them, you realise that each pathway has got very different needs, not least because of the way they are organised, how they are staffed, and the type of clientele who need support from those pathways. So no job like this had ever existed, and I spent a fair bit of time trying to figure out exactly what the team and what the clients needed from me. Now, I must confess, to this day, it still isn't entirely clear, and it continues to be a work in progress. Now, that is really exciting on one hand, but it's really quite tricky on the other. And so I've tried a few things up until now. What the team had initially asked me for was they wanted an advanced practitioner. They wanted someone who was able to prescribe and who was really able to run with kind of treatment plans related to medicines. So as part of that, I've been starting people on cognitive enhancing medication like donepezil and memantine, both for people with new diagnoses of dementia and people who've got existing diagnoses. And really coordinating that as a small part of their post-diagnostic follow-up. One of the largest pieces of work I've done is really looking at some quality improvement for clients who have a dementia diagnosis, who are prescribed antipsychotic medicines. We know that in this subgroup of clients, these medicines present more of a risk than they do to other people, not least the risk of sudden death, but also the risk of stroke. Older adults in general tend to be susceptible to, or more susceptible to, the side effects of psychotropic medicines. And so they are at risk of things like extrapyramidal side effects, which can encompass Parkinsonism, akathisia, dystonia. But there's also a statistic I've seen that up to 10% of people who are treated with antipsychotic medications can end up with a severe gait disturbance as well. You know, we already know about the risk of falls in older people, and that's just another part to add to that risk ratio. So I was focused on looking at these people who were treated with these medicines. The current practice had been that once the indication for that antipsychotic being prescribed had really settled down, it's usually for physical aggression or psychotic symptoms. Once those symptoms had subsided, the psychiatrist was no longer involved in this person's care, and they would be cared for by a band 5 community psychiatric nurse who would visit them every so often, no clearly defined time point, no clearly articulated detail about the review that should be undertaken. And then as soon as they got to the 12-month point, which is what is dictated in shared care protocols for our responsibility as a secondary care service for monitoring these clients, 12 months from initiation. Once that 12-month threshold was reached, then generally they were just discharged back to the care of their GP. So what I tried to do was actively review these patients with a view to reducing their doses of antipsychotics and attempt to withdraw wherever possible. I had a conversation with a colleague working in primary care who had told me that she had real difficulty knowing how to proceed when she was reviewing people in 24-hour care who had a dementia diagnosis and they were prescribed antipsychotic medicines, because in her experience, it's pretty much impossible to establish what the plan had been for these medicines in the longer term. And actually, most of these clients are no longer open to secondary care services. So with this in mind, I'm trying to ensure that discharge communication from our secondary care services to GPs and primary care colleagues clearly specifies what should happen with these medicines. So if people are still prescribed them, whether there could be a point where these could be stopped or reduced. Or similarly, if the recommendation is that these medicines should remain unchanged, clearly documenting the rationale for that. people with a dementia diagnosis prescribed antipsychotic medications feature very, very highly on the priority list for GP practice pharmacists, for the meds optimisation and care home pharmacists, because of the risks that exist. And so if they can lay their hands on documentation that clearly says what should happen, then they know they don't have to be as assertive with their intervention, because they know that it's been considered and it's been actioned, and they can, you know, ensure that that patient is getting the care and treatment that they should be getting. So one of the other streams that I've been working on is supporting people who have established benzodiazepine dependence to try and reduce this. It's something that one of my consultant psychiatrist colleagues had said it was something she really felt that she was inadequate at actioning, because, as you're all aware, that the time taken to action these plans is often really, really prolonged. And she just couldn't justify keeping someone on our team's caseload for that long when they had no other ongoing mental health care and treatment needs. That's not one of the things we're commissioned to do. So she asked if that was something that I could look at alongside the other work that was ongoing where appropriate. Now, I've had some success with this. I'm sure many of you can appreciate that benzodiazepine withdrawal is not particularly straightforward, but it's something that we've been working on that wouldn't ordinarily have been tackled before I was involved with the team. One of the really good points about doing this job is I've had the pleasure of developing some excellent partnerships with pharmacists and technician colleagues working in care homes, working in GP practices, and my PCN colleagues across the entire county. As I mentioned, I work in Northumberland, which is a vast area, and having these colleagues in community who, as I jokingly say, speak pharmacy, I underestimated quite how useful it could be for improving things for clients. But having those discussions across the interfaces, of which there seems to be an ever-increasing number, it really improves services and minimises risks around medicines for our clients. And I'm hoping to drive that forward in the next 9 to 12 months and really strengthen those relationships, broaden those relationships, and carry on those improvements. So most recently, I've been supporting our team to develop a physical health monitoring strategy for our patients who have specific physical health needs related to medicines. Something that our trust has done really, really well is have the policies and protocols that really underpin the principles of physical health monitoring in relation to psychotropic medicines. Because of the way the trust's organised and having different pathways, it's not particularly well embedded in the older adults pathway as yet. And I would contrast that to, say, one of our working age adult pathways. More often, these working age adult clients tend to be prescribed medicines like clozapine, like lithium, like depot injections, all of which demand a certain level of stringent physical health monitoring. So it seems to have been buried into their procedures and their practice much better than it has within the older adult service. It is improving all the time, but we don't have any dedicated services. So it's our community psychiatric nurses, it's our clinical support workers who are doing this alongside their day job of being a CPN. So I'm supporting them to try and get some kind of locally agreed procedures on how these things should look, and they've really, really jumped on board with it, and they're really grateful to have that expertise involved. So that's an ongoing bit of work at the moment. In the future, what I plan to look at is focusing on improving the service that we as a community mental health team provide to our clients who have been inpatients in our hospitals. Usually these admissions come with a number of changes to psychotropic medicines, as I've already mentioned, can cause all manner of troublesome side effects. These patients on discharge are followed up within 72 hours by their community psychiatric nurse, and that's because the first 72 hours following discharge from hospital have been identified as the most risky for those patients. one of the things that comes up often as well is, again, crossing that interface between secondary care and primary care in relation to changes in medicines. And so I'm looking at sort of more rapid follow-up on discharge from hospital to iron out things like that. But also from a clinical perspective, making sure that people are aware of the changes in their medicines, making sure they're tolerating them okay, and just a continuity of that dedicated service they get from the pharmacy team as an inpatient, carrying that on into the community. So it's a constant voyage of discovery, and I'm sure there will be more things that come up over time. But doing this job over the past couple of years really helped me to understand there's so much that's unknown about this area of work. And I didn't realize at the time, but it sparked an ambition in me that I hadn't been too aware of. And so earlier this year, probably a little bit longer than that, I decided that I wanted to take my first tentative steps into the world of research. And so earlier this year, I set about applying for funding to help me get my foot on the first rung of the research ladder. So you can see the banner there. The NIHR are a government body that funds, enables and delivers world-class health and social care research that improves people's health and well-being. The Integrated Clinical Academic Programme is a development programme that provides research training awards for professionals with a non-medical background to pursue careers that combine research and research leadership alongside continued clinical practice and professional development. Now, there's a number of different programmes that you can apply to, but given my experience and being at the very beginning of a research career, or a so-called early career researcher, I applied to the one you can see on the screen there, the Pre-Doctoral Clinical Academic Fellowship. There were two things predominantly that attracted me to this programme. The first is the continuity of clinical practice. Whilst I had ambitions to pursue some form of research career, I wasn't keen, certainly not at the moment, to leave clinical practice entirely, because for me, having that face-to-face contact and that involvement with my clients is really the best part of the job for me. It's what makes it worthwhile. So I didn't want to leave that behind entirely. Now, you don't spend your time going through your career like I have without earning some financial recompense for that and getting yourself to a good salary. And the thing about this programme is it means that you can maintain your existing salary whilst you go off and do something a little bit different. So the programme funds a proportion of your salary to release you from your day job. So as part of this fellowship, you undertake training which you've specified according to your identified needs before preparing an application for your PhD. Now, in my experience, the application is quite stringent, and I'm told that's because these programmes cost a lot of money to deliver. These bodies are investing a lot of money in you as a professional, so you need to demonstrate that you are capable of it.
For those of you who don't know me, I'm a pharmacist. I work with South Tees Hospitals Trust. I work in the oncology department there, and I am about to submit my consultant pharmacist portfolio at the end of this month or beginning of next month. So my post has been accredited to be a consultant pharmacist post, and I'm just in the process of proving, hopefully, that I'm good enough to be a consultant pharmacist. So I'm going to talk about various things in this session, partly how to get hold of data to work with, how to some of the challenges of working with others. I'm going to talk about how either to break your own data or how other people might break your data, just very briefly. I'm going to talk about study design at a very high level, just some concepts, and some of this is more reflection on how things have evolved for me. I'm going to talk about trying to make sure we pick meaningful outcomes rather than outcomes that are traditional to pharmacy. I'm going to briefly touch on data protection and some of the changes in the rules that have come in around that. And then I'm going to try and link all that together with how some of that fits into the consultant pharmacist framework. So the consultant pharmacist framework, for those of you who don't know, has 5 domains. There's a patient care domain, a communication domain, a leadership domain, an education domain, and a research domain. And since this is a research conference, I'm going to concentrate purely on research. Within each domain, it then splits out into a number of areas, and then each of those areas splits out into more detail that describes the behaviours you should have to prove that you can do things. So the first is that the first research criteria is that you should be able to critically evaluate literature and evidence. The second is that you should be able to identify the evidence gaps and then design research to generate new evidence to fill some of those gaps, and that you should be able to work collaboratively to support research. So I'm going to try and talk through how some of that happened for me. I'm going to start, most of my presentations run with a story, and that's how this will begin. So a few years ago, when biosimilar rituximab was being introduced, we involved various people in some discussions of trying to preempt what the concerns might be around implementing biosimilar rituximab. It offered significant financial savings to the NHS. And so we wanted to be able to do it as quickly as possible, but we thought there might be some clinician resistance. We thought the most likely area of resistance might be that if we were unlucky enough to have the first patient who we gave it to had an infusion reaction, then of course instantly everybody attributes that to the new product and suddenly there'll be a lot of resistance. And to make matters worse, we couldn't simply say we should follow the evidence that's been published on the biosimilar, because the biosimilar used the licensed infusion rate. And within oncology, or rather within hematology, we use rapid rituximab, so administration over 60 to 90 minutes instead of administration over 4 to 6 hours. So because we're giving it quicker, it's possible that our infusion reaction rate might be higher. Our first question was, well, actually, what is our baseline reaction rate? And we didn't know. There's no system that reliably collects that data. You can go and look at yellow card reports, but virtually nobody would report those reactions because they're expected reactions, even though sometimes they might be quite severe. You could go and look at your IT systems in your trust, but virtually no trust has a useful way of recording that kind of information. So it'll be free text recorded somewhere, and the quality of that data would be very poor. So we thought about what data we might need to collect, and we started to think about what other confounders there might be. So would it be the dose that might change things? Would it be the cancer type that the patient had that might change things, etc.? And we knew from a previous project I'd been involved with that different people would tell you that an allergic reaction had been severe or very bad or whatever, and actually you needed a consistent way to be able to score it. Even though we have a consistent way within oncology for scoring toxicity, application of that still remains quite varied. And then once we had that, we thought, well, how many patients would we need to look at to be able to give a meaningful answer? Most of these sorts of projects that you're doing, you might only have 20 patients in your trust. And if you've only got 20 patients in a trust, it does coming back and saying, I've got 2 patients out of 20 who've reacted. Does that give you any reassurance or not? So we started off by going back to the literature and reviewing the literature. We found several papers and did a meta-analysis on those. So we got nearly 2,500 patients in 2 different rapid administration regimes and got an allergic reaction rate of just under 10% for any grade of reaction and less than 0.5% for the more severe reactions. We took the confidence intervals around those estimates and said, well, actually, if we're using biosimilar rituximab, we should hope for a reaction rate less than the upper limit of the confidence intervals. So 10.8% and 0.7% were set as our audit standards. And we, in a collaboration of discussion with other people, effectively brainstormed the factors that we thought were likely to be contributing factors. There was a bit of literature review sucked into that, and we came up with 52 data fields that we wanted to gather data on. We built an Excel spreadsheet. I'll talk more about Excel spreadsheets later probably, but Excel spreadsheets are very convenient as a way for people in different organizations to populate data and then to merge that data in later. They're also a very convenient way for people to send you data that's not structured in quite the same way as you intended them to. This was probably my first experience of collecting data from multiple organizations on an Excel spreadsheet and discovering that people would just enter dates in different formats and things like that. However, at the end of the project, we ended up with 75 patients worth of data, slightly less than we'd hoped for. We struggled with recruiting hospitals to be part of the project because actually it turned out not to be as big a concern as we thought it would be. but we got data from 116 rapid infusions, and the infusion reaction rate was very low, so it was quite reassuring. And so we were able to carry on safely giving rapid infusion rituximab. There's been a similar project from one of the very big London hospitals who had about 100 odd patients themselves, and they've also published their data and shown that there's no significant difference in infusion reaction rates there either. The next project that we came on to talk about was a meeting of NHS England cancer commissioning pharmacists, and it was a discussion around waste. One trust was saying, we think we're being charged for waste centrally into NHS England, and we're not sure if we should because NHS England doesn't control that waste. And the NHS England commissioner said the person who should be paying is the provider, they've created the waste. And someone else would say, but actually there's trusts who tell us they have no waste, but they're probably just burying their costs, and so we don't think that's true either. And then we got to the fundamental question of what did we mean by waste? And it turns out that everybody means a different thing when they talk about waste, particularly waste with chemotherapy. So we had a situation where one provider would say waste with chemotherapy meant we made up a bag of chemotherapy, we sent it to the chemotherapy unit for the patient, and the patient wasn't well and didn't get it, and that's clearly waste. And another provider would be talking about the dregs at the bottom of the vial, they used half a vial and didn't use the rest. And different providers would argue that their model was producing less of one waste and more of another and so forth. And actually, it didn't matter which one was which, because we said what matters is how much drug got given to patients for the cost that we're spending. So we said if we had an ideal data set, we would simply have a table from each trust telling us for each drug how much drug they used, how much drug they'd given, and we'd be able to work out how much of that drug was wasted. We said, well, actually, those first two columns could come from your pharmacy computer system. You already know how much was used by the pharmacy. And the two purple coloured columns should be able to come from a data set that's routinely being collected in your e-prescribing system for chemotherapy, known as the SACT data set. It's a data set of 43 fields for every single dose of chemotherapy that's given to a patient, uploaded to Public Health England at the end of the month. So we said the data's there, we just need to get it into the right form. If you go to your pharmacy system, as an example, what the Ascribe system might produce, and as you'll see, it's got data on there for chemo drugs, but it's got non-chemo drugs, it's got patient identifiable data. So let's start by filtering off the things we don't want. So we didn't need to get down to patient-specific level, and we certainly didn't need to know about the non-chemo drugs. Ascribe also shows things that were manufactured in the aseptic unit, so we'll hide those off too. And we get down to just the raw ingredients of chemo produced. You could filter that out in your reporting system, or you could filter it out once you've reported it to do it later. And we said, well, actually, none of that tells us how much bortezomib we've used, because the only place that the quantity of bortezomib is anywhere to see is in the description, and we can't process that information. So we built a lookup table which took the product codes and was then able to tell you that bit of information. So we needed to do a one-off bit of work to create that information. It doesn't take terribly long to do, and you can then reuse that multiple times as you rerun the data. You can then join that, and joining is a process that you can do in good quality data analysis packages. You can even do it in Excel with a little bit of effort, so that we could pull up into our original data set the number of the drug name rather than a description with lots of other information, and the number of milligrams in that vial size. We could then calculate out from that the actual number of milligrams used. So you'll see on the third row down that they used 2 vials. So instead of being 2.5 milligrams, it's 5 milligrams. I'm talking you through some very simple maths here, but to try and make this make sense. Then we summarized that for monthly data. We didn't need to work on any more level of accuracy than that. So you got the total number of milligrams of bortezomib you used in a month and the total number of milligrams of carboplatin. We did this for 20 drugs, but for the purposes of keeping the screen reasonably clean, I've just looked at 2 drugs. Then we took the SAC data set, which is this giant data set of data that every trust is uploading. There's multiple fields. I've just selected out the relevant bits. Again, we didn't need any of the patient identifiers, so we just deleted those out of the data. And we only wanted certain drugs, so we deleted drugs we weren't interested in. And again, we summarized that by drug. And we got a table that looked something like this. So this was the number of milligrams we'd actually recorded as administering to patients. And then we merged those two together to get the same information all in one table, and then you could calculate out the waste as the number of milligrams wasted. Depending on your viewpoint, you've wasted more carboplatin than you have bortezomib, because carboplatin you've wasted 50 milligrams of, and bortezomib you've wasted 5.2 milligrams. But if you look at it as a percentage, it's higher. And if you look at it as a cost, which was the discussion that we started out with, then actually you're wasting a lot more on the bortezomib, and that's where you should focus your effort. Each trust, so we then collected that data across all the trusts in the country being England, for 20 drugs of interest, and gathered up some data, and we're able to produce a number of analyses of that in a variety of ways. But one of the things we were able to do was produce this waterfall plot that showed the expenditure wasted. So if your trust was spending £1 million and you were wasting 25% of your chemotherapy drugs, that's £250,000, which is quite a lot of money. And so you could see where you as an individual trust were. This is just an extract taken from one of those reports, and that red arrow is where that individual trust lay, so just below the median, so they weren't doing too badly, but there was room to improve because there were trusts who were doing better, but you certainly wouldn't want to be a trust on the right hand side. And it helped trusts to identify whether or not they were doing okay or not, because up till then they didn't know. Good research always generates new questions of its own, and in fact that's pretty much what this project did. All it did was gave people an opportunity to debate the data more, so people were starting to ask questions about why their waste was higher, or what they could do to reduce their waste, and it got people talking between different trusts, because they could go and say, well, your waste's lower, what are you doing different, and so forth. It got people to challenge the data, and we absolutely expect that there are trusts in there that have data that was flawed, but if that all it did was meant that they went and improved their data for their SAC data submissions, well, that was a valuable exercise in itself. But one of the important things for that whole project was that it got people to start saying, no matter what we do, we need to reduce waste, because we are wasting tens and hundreds of thousands of pounds of chemotherapy a year in individual trusts, whereas until then, nobody had ever put a financial value on it. That then brought me to my next project. So my clinical director does my appraisal now rather than my chief pharmacist, and he sat me down for what I assumed would be my routine appraisal, and he started off by complaining about the number of new treatments we kept getting approved and how busy we all were, and the fact that we didn't actually have enough time to manage all of this, and the fact that more oncologists are retiring and the whole problem was getting worse. And I said, well, that's why you've employed me. And he said, well, yeah, that's great. And, you know, it's great that you're fully trained and you've got bits of paper to show you're a non-medical prescriber, but what's the evidence this works? And I said, well, the evidence is easy. The evidence is this publication from 10 years ago that says non-medical prescribers make less prescribing errors. And he said, well, actually, making less prescribing errors is fine, but I make prescribing errors all the time and pharmacy pick them up and fix them, so the patient doesn't come to any harm. How do we know that you make the right clinical decisions for the patient to proceed with their chemotherapy or not proceed with their chemotherapy? That will never get recorded as a prescribing error. And I gulped a bit and said, I don't like the sound of this. This sounds like it's going to be hard work. And I said, almost at the same time as he said it, how do we know doctors are safe? What we do with doctors is they present all their cases of death within 30 days of chemotherapy at a monthly meeting. And I said, well, that's easy. I'm doing that too. So my cases go to that meeting. And if I was the last person to see the patient, I present the patient. But I only present 1 or 2 patients a year because, fortunately, we don't have that many deaths. And so we then said, well, the meeting's called morbidity and mortality, we should look at morbidity. So that's what we decided to do. We took the first week of each month for the first 3 months before COVID hit, and we looked at all my clinics and went through, merged in some SAC data in much the same process as I've described for the merging in of other data. And then we went through our other clinical systems and identified whether or not the patients got admitted to hospital within 30 days of chemotherapy or died, or whether or not they got admitted before their next clinic review. We didn't know which outcome was the right one to use, but we've now actually settled on the 30 days. And so we did that to prove that we were providing a safe service. And indeed, this is a poster we published last year at the BOPA conference, where we showed that actually our rates of hospital admission are very similar. They meet or are less than, in fact, the expected level in the one published paper of rates of hospital admission after chemotherapy, and that there's no statistical difference between the two. And as we did that, we'd built quite a lot of automation behind producing that information, partly because I'm lazy and partly because I'm a geek. So I didn't want to have to go away and look up lots of bits of information. So then we started to sit down and say, what else can we do with this SAC data? We keep sending off these reports to Public Health England every month. And while Public Health England send us back some summary data occasionally and tell us where we've got gaps in our data and so forth, we're not doing anything that's going to change patient care with that. One of the clinicians said, but it's missing survival data. That's one of the problems with SAC data, is that we only can tell Public Health England that they died if they died within 30 days of their chemotherapy, because we upload the data within 30 days. And I said, well, hang on, we uploaded the survival data from a different system for the last project. We can redo that and merge it in with the SAC data. So that's what we've done. This is a work in progress. This paper will be hopefully published in the near future. So we've purposefully hidden the details of what the regime is and so forth at the moment. But these are 3 chemotherapy regimes funded by NHS England to treat the same cancer. Clearly, you'd want the red line, which is the most effective treatment. The other 2 treatments we tend to use if you're not fit enough to have the red line, but the green line is pretty much not any different to the blue line, but is a much more expensive treatment. It's never been in a head-to-head study quite how it should have been as a clinical trial, and so that's what our paper will challenge, is whether or not we're using this treatment in the right setting or not. But this is a clinically meaningful outcome for patients. This isn't an error rates or anything like that, which is the types of thing pharmacy would tend to traditionally look at. Part of that project required that we started to look at, when we come to publish that data, we're going to have to be squeaky clean in terms of information governance. We didn't want to get in a situation where we couldn't publish because we hadn't got patient consent, but you don't need patient consent to use data that's already been collected. But as you're probably aware, there's a little bit of a public outcry at the moment about NHS Digital taking data from GP surgeries and being able to share that data with other people. And there is a 2-tier process for opting out of that. So you can either choose to opt out of your GP surgery, supplying that data to NHS Digital, or you can choose to opt out nationally to stop NHS Digital using any data they've got. If you opt out nationally, that actually applies to trusts not being allowed to use that data as well. So we said, well, we better comply with that process. In fact, it was supposed to be a mandatory process from the end of March, and it's just been moved to the end of September. But we've complied with that process anyway. So we've been through that process, which involves sending off effectively a list of all the NHS numbers that you want to do your data analysis on, waiting for a reply, which takes about half an hour or so, and you get back a reply of all the NHS numbers you're allowed to do your analysis on. And for our 1,400 patients that we've got in our SAC data set, about 300 had chosen for their data not to be used. So it's not that many really, and it's the right thing to do to exclude them. That same process should be applying to any use of NHS patient data for any purpose other than patients' direct care. And that's going to present some challenges, and we'll need to think about how you do that. That process of joining that I described earlier data is exactly the same process we used for that. Clearly, we weren't going to go through 1,400 individual patient lines of data. In fact, because there's a line in that data for every time we give somebody chemotherapy, there's about 350,000 lines of data. We certainly weren't going to go through 350,000 lines of data looking for 324 patients. So we merged that all automatically. The rest of this diagram I've left in purely because I also wanted to talk about how you think about how you write up your publication. So if you come to publish this in a peer-reviewed journal, you'll be asked to provide a consort diagram if it's a clinical trial, or a strobe diagram, which is what this is. The 2 are very similar. If it's a observational study, which is what ours is. And that helps you to define what happened to your data and your patients, and about how your data becomes reproducible. But I think it would be very helpful if you're thinking of designing a research project that you think you might want to publish in a peer-reviewed journal, that you actually go and look for what the requirements are for journals. And that usually means looking at the Equator Network. They have a website which will then tell you what standards you'd expect it to meet. And that would usually say you need a consort diagram or a strobe diagram. So I just thought I would put that in more as a prompt to remind me to mention it. And these 5 things are my top 5 tips. So these are the sort of 5 things I would say to you if you are thinking of being a consultant pharmacist and wanting to do research. These are the things to think about. You need a network, and that network might be within your trust, that network might be nationally. That network will start discussing and generating questions. You're likely not to do that in a way that is set out where you say, oh, it's Tuesday afternoon, we sit down and have our what research do we want to do afternoon. This is much more likely to be people just discussing patient care or challenges that you might be having and how to proceed from there. That's how almost all of my research has started, is that a group of people, it might be 1 or 2 people, it might be multiple people having a discussion, and it depends whether that's in a trust or wider, which starts to ask a question. And then you need to start to refine those questions, and you might use your network to do that. And the other reason a network's really useful is that they can share some of the work, so they can either provide data from multiple trusts to make your data set bigger, which will make things much more meaningful, or they might share some of the work in terms of the analysis or data collection if it's a manual process, which means you can get results quicker, which means you can make differences to patients quicker if there's a difference to patients to be made. When it comes to designing your study, think about the outcomes that matter to patients. I think we need to get away from traditional pharmacy outcomes, which are usually around drug savings and usually around errors and things like that, and start to think about the outcomes that actually matter for patients. So if we're making drug savings, can we actually show where we've made the investment, where that money that was saved got spent on other things or whatever, which might be a useful way of looking at it. I've mentioned looking at the equator network so that you design your study from the start to be right. The other thing I would say is try to understand the research methods or the statistical methods behind what you're doing. You're probably not all going to become statistical experts, but if you think back to that Kaplan-Meier survival curve that I showed with the 3 lines, understanding how those lines are created and what they mean helps you to understand what data is you need to collect. So to draw a Kaplan-Meier survival curve, which is something that is gold standard in any oncology project, you need to know, has the patient died? But you also need to know, if the patient hasn't died, when did we last know they were alive, what we would call a censoring date. And if you've got that information, you can join all the other bits together. I would encourage you to join data from multiple data sets together if you need to, and I would encourage you not to manually enter data if you possibly can. I still have projects that are involved in manually entering data. It commonly will produce data entry errors, and it actually makes life more difficult because people are doing things twice. It'd be much better to get the data entry right on the original clinical system and then extract that data out if need be. And then if that data is in multiple systems, extract the data out with a common identifier like their NHS number. You can join them together without an awful lot of effort. Pick the right tools. So almost all of my research has involved Excel, and for the main reason that Excel's installed on pretty much everybody's computer. We've got a current project going on which includes hospitals in Scotland and across the whole of the UK, and Scottish Excel is at least 1, if not 2 versions older than my Excel, and I've got other trusts who are at least 2, if not 3 versions of Excel more modern than my version of Excel. And every time we hit a data problem, the first issue we have is we don't know whether it's their version of Excel that's breaking something or something we've done in the Excel spreadsheet. There are things you can do to try and reduce the risk of people breaking data. Dates in Excel I find particularly problematic. People enter dates in funny ways. They put decimal places in instead of slashes. If you have international people, you will get people entering American date formats of month, day, year. And even if you don't do all of that, for reasons that are difficult to understand, Excel might just suddenly decide to do that. With the waste project, we had data coming from 150 trusts, and despite the fact that the Excel spreadsheet was designed specifically to give the data output in day, month, year format, it would seem that if your trust's standard configuration on the computer was month, day, year, the data we got sent was month, day, year. So we had to then work out which trusts were sending us that in the wrong format, flip it to the right format so that we didn't break other things. But one of my biggest problems with Excel is it's not reproducible. So you can collect all your data in Excel, but if you do your analysis in Excel, if you've got your first 100 patients' data, you probably want to have a quick look and make sure you're collecting the right bits of data and start to run some of your analysis and think about how you might structure your report and so forth, even though you might want 1,000 or 2,000 bits of data. If you do that in Excel, you do it once, and then in 6 months' time, when you've got all your data in, you have to do it again, and it's not going to necessarily be done in exactly the same way, and lots of clicking and so forth. When we did this for the waste project, we wanted to do exactly the same analysis across 20 drugs, across 150 trusts. I can't do the maths in my head, but there's quite a lot of times of doing the same analysis. So it's better, if you can, to do it in the right tools that will reproduce things for you. And then finally, my thoughts are around how you publicize and share your work. So there's obviously things like bringing work to conferences like here. There are online discussion forums to go and discuss things, and that's a good way of networking. It's also a good way of shouting about something you've done. Twitter, while it's a evil, horrible social network platform for Donald Trump to publicize his wills with the American people and so forth, the reality is that it's also a very good platform for medical professionals to share data and information and research and ask questions. So if you stick to purely sort of medical or pharmacy Twitter within Twitter, then actually you can use it as a source of CPD. It gives you pointers as to where to look for things, and you can use it to shout about your own bits and pieces of work. There's a social network platform called ResearchGate. They probably don't call themselves a social network platform, but that's effectively what it is. It's a file sharing system where you can upload details of the current projects that you're working on. And for about the last 3 or 4 years, I've been uploading projects that I've been working on into ResearchGate as a way to leave a copy of a poster after a conference to still be accessible and visible. And then finally, think about publishing in journals and so forth. When it came to writing up my consultant pharmacist portfolio, being able to go back to ResearchGate and pull off all my posters and so forth was very useful. The other thing that ResearchGate was useful for was being able to find people who had similar interests, and sometimes people will just randomly send me a message. Sometimes for a project that I did maybe 10 years ago that I've put on ResearchGate and I've pretty much forgotten about, but somebody might just drop you a message out of ResearchGate all of a sudden to say, we're looking at this locally or whatever, often from another country. So those are my top 5 tips as to what I think would be helpful for people who are thinking of going down the consultant pharmacist portfolio. I haven't been looking at the chat, and when I tried earlier, I nearly lost the presentation. So I don't know if anybody can tell me whether or not there is anything on the chat.
There's a few questions, Calum.
Yeah.
Actually, since it's a small group, why don't you just unmute yourself and ask Calum directly? I think Julia was first. Then Jessica.
Comment really about, I just agreeing with Calum's point on moving away from focusing on the process, although obviously we want to remain safe, to just a more meaningful patient experience in terms of outcomes, particularly in obviously an area like cancer, but in any healthcare area. Just pleased to see that point raised, I guess, and obviously Calum's point about perhaps having that reflected back in your meeting that you had with the clinical director, and just expand a little bit on how that had led you to a different way of thinking.
Yeah, so my CD does my appraisal. So my appraisal is not done by pharmacy. So that's changed the whole way my appraisal works, because he's a doctor. Doctors don't really know how to do appraisals. I think they would openly admit that. And so he said, I'll just do it like I do the other doctors' appraisals. And so he challenged and sort of said, you know, we need to look at outcomes. And actually, in terms of research, that's the bit that matters. And when you think that actually pharmacy does lots of bits of research, but it probably doesn't make it very often beyond the pharmacy sphere, I wonder how much of that's because we're not looking at outcomes that really interest other people. We look at outcomes that interest pharmacists. And if we want to make our research really start to count, then maybe we should start to look at outcomes for patients.
Javed's asking, is there how can we collaborate with you?
So if people want to collaborate on cancer projects, I'm more than happy. So the easiest way to get hold of me is probably to find me on Twitter. I'm a bit of a gobby git on there, so I'm known as Shiny Black Shoe on Twitter. Or you can drop me an email at calum.polwart@nhs.net. I'm Calum with one L, that's the only tricky bit. So Polwart's with Polwart. Drop me a message in the chat and I'll pick up an email address, whatever you want. If people have things they want to talk about, I'm more than happy to. I'm equally a hardcore geek, and so if people want to talk about data and how to do things with data, you know, that doesn't need to be cancer stuff. I'm more than happy to have a conversation, point people in the right directions and so forth, and get involved with things that aren't cancer. If it's how can we do some cancer data, then absolutely I want to talk.
So welcome to this session. This is all about how we start to work better together. So my role is I'm a pharmacist. I'm the Chief Officer of Avon Local Pharmacy Committee. And for those of you that don't know where that is, that's down in the southwest, and it supports about 220 community pharmacies around the Bristol and Bath area. Not only that, I'm also a senior visiting lecturer at the University of Bath in the Pharmacy and Pharmacology department. So it's great to be able to come and talk to you today. I suppose it's fantastic in this sense because we can do all of these things now remotely in ways that, you know, we couldn't have done before. So it's great that we're able to sort of share ideas across the country. And certainly I've enjoyed listening to some of the things that are happening up in the north as well as part of today. So let me make my presentation move. So for me, I suppose what I'd like to talk to you about is, you know, raising awareness of the fact that community pharmacy is changing. For many years, the community pharmacy contract was based predominantly on dispensing prescriptions, but it is, you know, over the past couple of years, and certainly with our 5-year contract that we now have in place at the minute, we are moving much more towards delivering clinical services. And for me, that's fantastic. That's the way I've always wanted it to be. You know, when I was practicing on a regular basis, I spent a lot more time trying to be out on the counter, talking to my patients, interacting with my local community, forging great relationships with my local surgeries, and really so that my patients saw the community pharmacy as the place they would visit first. And then beyond that, you know, I might escalate them to the surgery, or if it was more serious, they would end up in the surgery. And that's what I like about the whole idea is improving outcomes for the community. And it's certainly been, you know, highlighted during the COVID crisis is one of the most accessible places in primary care has continued to be a community pharmacy. And certainly the public have looked for that, which is fantastic. And that then means we start to become, like it says, like an integral part of primary care. It should really be, from a patient perspective, a seamless journey through health. And even now, even with services that are being commissioned around the discharge medicine service, we're finally starting to get services that bridge both the secondary care environment into the community pharmacy and general practice pharmacy environment. So I think it's looking really exciting for the way that we're starting to do things moving forwards. So looking at that in a bit more detail, let's start with the community pharmacist consultation service, which has been commissioned and has been now live for, I'm going to say, for 18 months, maybe even longer now, with referrals for common ailments coming from NHS 111. That's been around for some time, and that's where if a patient contacts 111 with a condition which is on a list, you know, from skin rashes to constipation to mild pain, whole range of them, 111 call handlers can actually then formally refer those patients to a community pharmacist. They will have a private consultation with the patient, and then they will manage that through either self-care products, through advice, through over-the-counter products, where PGDs are available, quite possibly through that route as well. Or in some instances, they'll actually then be able to refer the patients back into the professional line if they think that they need more care and support. Recently, we've gone live with a National Commission project looking at referrals from general practice for exactly the same way. And this is about general practice being able to grow the number of patients that it sees, in effect sees, on a daily basis, because the local community pharmacies could accept somewhere in the region of 10 referrals a day from GP surgeries. And what that means is that frees up 10 appointments a day to be filled with more complex patients. And this is a service that in my LPC, because we were part of the pilot, we've now had somewhere in the region of 17,000 consultations has been referred into our pharmacies. And because the pilot was so successful, that's now been rolled out nationally and it's been part of our service specification since kind of last November. But in reality, it's only been in recent months that the rest of the country have been able to start to implement it as some of the COVID pressures have started to reduce. So just to give you a bit of an idea as to what this sort of service looks like, there is a real misconception about what this service looks like in reality for the patients. A lot of people think that the patients who are going to be referred out of general practice into the community pharmacy are elderly and comorbid. I think the graph on the screen at this moment in time shows that that is just not the case. What it generally turns out as being is parents with children, where in a lot of instances what they need is support and the acknowledgement that it's okay and that reassurance that comes with that. Or alternatively, middle-aged people that have maybe got a condition that's just lasted for, say, 3 or 4 days and it just isn't going away. So they think, actually, I'll access the health service. And where do they go to access the health service? Well, they just phone up the doctor. So that's the vast majority of patients. And therefore, it's really important that we share that message, because as part of general practice working with community pharmacy around this service, it's about understanding that risk profile and that these are people that would turn up to a pharmacy normally, but in this instance, they've chosen to access general practice. And these are appointments we can absolutely free up, because then that gives more availability in a surgery for the 60, 70-year-old plus patients who actually have more complex needs and therefore need to see a prescriber. Some of the conditions, hopefully you can see some of those. You won't see the ones in the bottom corner. They're just so small, even I can't see them on my screen when I produce this graph. But as you can see, most of the conditions, things like skin rash, you've got sore throats and hoarse voice. We've still been seeing patients like that. Unfortunately, pharmacists are a bit of a pain for selecting other on a regular basis and then realizing that they could have actually selected one of the ones from the drop down box. Eye conditions, ear conditions, cold and flu. We see hay fever things at certain times of the year. Pain is in there, bites and stings, headache. So real common things, but these are people that otherwise would have presented at the doctor's surgery, and actually the right place for them to present is the community pharmacy. In terms of outcomes for these patients, the big blue piece, sort of 38%, that's where patients are given advice alone. No sale of a product. And that's one of the key things for this service, which is where we're going together, is there is nervousness that, well, will people buy products? Well, actually, in nearly 40% of the cases, all the patients need is advice and reassurance. In about another 30% of cases, they probably will require some form of product, which the pharmacy can sell them. And then beyond that, you know, the grey box is the patients that actually get escalated back to the surgery. And they're probably about 1 in 10 of the patients that actually do need to be seen by the surgery and quite possibly need to be seen that day. And I think the way that those patients are then handed back to the surgery is actually how we're starting to build really good relationships between our pharmacists and general practitioners, because there's a conversation then around that clinical presentation in the pharmacy, any red flags that might have been observed by the community pharmacist, and equally that recognition of how quickly they need to be seen back in the surgery. And let's be honest, we have had patients whereby we've actually had to call 999 because they needed to be seen immediately. And actually the community pharmacist in that instance has actually acted as the safety net for the system. Where does that go from here? Well, what we're starting to see now in development is that we're starting to look at whether we can take referrals from the minor injury units or potentially A&E departments. So again, these are sorts of ways in which this service can be further developed and to start looking to lift more work out of the system. And certainly at this moment in time, the system has never been under more pressure. It's like everybody that has been needing to present over the last year, it's like the cork has been removed out of the bottle and everybody's flowing back into the system, you know, and I'm sure you guys are seeing that sort of that increase in pressure. So again, if we can start to take more of that burden of pressure out, and certainly minor injuries and accidents and emergency departments, those referrals, we expect that they would happen in evenings and weekends when generally a community pharmacy is at its quietest. And then what supplements that is the development of PGDs. So we have a minor injuries unit in Bristol that sees about 50 women every single weekend for urinary tract infections. Well, actually, for the uncomplicated UTIs, absolutely we should be seeing them in a community pharmacy setting, probably closer to where they live, which makes it easier for the patient, but more importantly, reduces pressure on the out-of-hours system. We can move on to the discharge medicine service, and I think this is a really, really important one for finally a service which is actually commissioned across the whole of the pharmacy spectrum. So you've got the initiation of a referral from a acute setting or some other form of hospital-based setting, and that then sends a electronic referral to the pharmacy for them to carry out a 3-stage process with the patient. Part of our essential contract now within community pharmacy, but is obviously dependent upon hospital colleagues actually initiating this. And certainly from my experience of probably about 15 years ago, when I had to sit and spend time with a pharmacist who had inadvertently given out a prescription to a patient who had been discharged. Now, they had no idea that this patient had been into hospital. The GP practice hadn't even yet processed the discharge summary that had gone to the surgery. But ultimately what happened was this patient contacted the pharmacy to ask for their medication to be sent to them. Pharmacist had no idea. They had a prescription already made up for them sitting on the shelf. They issued it to the patient, and as a result, the patient took the paracetamol that was in it. What nobody knew was that the hospital had also discharged the patient with paracetamol to take as well, and about a week later, sadly, they died. When the system looked back at the case review of that, there was no way that primary care could have known that this patient was in the secondary care system, certainly not primary care pharmacy. And it just goes to evidence the harm that can be caused when we do get this wrong. So it's important that we recognise the important role that sharing these discharge summaries can take. Hopefully, and it'd be interesting to see from when we start the Q&A, just to get a few more people's thoughts around this, because the pharmacist then, the community pharmacist, is then going to hook into looking at that discharge summary, is going to carry out a clinical review with that, is going to liaise with the GP practice pharmacist as well if they notice anything that needs to be raised. They might flag to the surgery that certain blood tests might be required after a certain amount of time post-discharge. They might want to make sure that the dose regime is correct. It's always good that let's get it double checked. What's really important with this service though is that the pharmacy will carry out a review of that first prescription that comes through from the surgery. I think it's remarkable still in this day and age with all the digital capability that we have, the amount of time when that first script comes through and it reflects what the patient was originally on before they went into hospital. So our hospital teams have done phenomenal work in terms of meds rec on admission, meds optimization, probably gone through some level of stop-start regime with the patient. They've discharged them with a brand new regime. They land back into primary care and bang, they get the same medication that they were on before it. And guess what? They cycle back round into the hospital. And I'm sure a number of you will have seen patients who are just on this cyclical way around. And we just need to get better at being able to support these patients. So our community pharmacy then, if they get a copy of that discharge, is in a great place to then be able to intervene before that prescription goes out. Thought I'd also share with you some data from what we're seeing in Avon. And this data is a few weeks old now, and it's only a very early snapshot of data because we've not had a massive number of referrals yet. About 2/3 of our pharmacies have received at least one referral, which is fantastic. The average has been about 5 that they've received over the course of about a 6 to 8 week period. So that's good. It's really starting to get going. But I thought I'd share with you some of the outcomes. Well, so far what we've seen is about 22% of patients that have gone through this stage 1 clinical review and also assessing if there's any old scripts in the system. In about 22% of cases, the community pharmacy has picked up something. Now, that's not me saying that that's something that was wrong at the point of the discharge. All I'm saying is that that's something they've picked up which could have led to a worse outcome for the patient. So nearly 1 in 5 patients, we're finding something. Sorry, just over 1 in 5 patients, we're finding something. Now, stage 2 is about that assessment of, is the first prescription that is issued the same as what was on the discharge summary? And again, in 12% of cases, we're finding that there are discrepancies between those two that we're having to rectify. So again, important that these reviews are being carried out. What's really pleasing though, in only about 1% of cases, are the patients having to then be referred back to their GP. So the good thing about this is that if this service isn't about increasing burden elsewhere in the system. This service is absolutely about the community pharmacist taking accountability for making sure that what that patient gets is right for them post-discharge. Also, just to touch on, when we're starting to talk about working together, what a key thing that we have to do at this moment in time, and that's all around the vaccination programme. It's still up in the air as to exactly what this year's immunisation programme is going to look like. But our we're going to have some level of flu vaccination, as we always do, and that will be spread across primary care from our GP colleagues, our GP surgeries delivering it, our community pharmacists doing it. Equally, there'll be some provision that will, of course, occur out of the trusts. But there is this unknown at the minute as to what the COVID-19 booster programme is going to look like. We're fairly clear in terms of what the cohorts are going to be and how they're going to be spread over about 15 or 16 week window over the course of autumn. And we've got to make sure that we then also deliver all of those boosters. I think it's going to be key as we go into the season that community pharmacies and surgeries are talking and working really, really closely together, because there's going to be some places that will be doing both vaccinations. Equally, there'll be some places that will be doing just one. And again, it's important that we manage that messaging correctly. My nervousness is, in some ways, is that a patient may go and get one of the two vaccinations and think wrongly that they've been covered for both. That's a big risk. We may have people that are unsure where to go in the system. Equally, we may not have vaccinations in the right place. We may have lots of people going through a small number of sites for their COVID vaccination, and those sites then running out of flu. And how do we make certain that those patients then are signposted on elsewhere? It'd be interesting as well to see once the results are out of the trial, whether it's even possible to co-vaccinate people at the same time with both flu and COVID. So there's still lots of unknowns. But as with anything in these sorts of things, it's the communication that we have across the different disciplines that actually makes this successful. When we start to work in silos and we start to only think about what's happening in our world, that's actually when patients end up falling between the cracks. So lastly, just to bring it all together, just to get you thinking before we kind of bring the section and open it up for a few questions. We have our surgeries and pharmacies that work together. Hopefully they are starting to build better working relationships with one another. And that's all of the different colleagues that work in surgery and all of the different colleagues that work in the pharmacy. Then at the next level, we're starting to work with primary care networks. Currently, that's predominantly surgeries that are coming together to work in that way, but more and more we're starting to see pharmacies becoming an embedded part of that primary care network. And that's absolutely right. And to be fair, it should probably go wider in the long run than surgeries and pharmacies, because dental services, optometry services, they're part of primary care. You've also got some of the social care services that wrap into primary care as well. So primary care is much bigger than even surgeries and pharmacies, yet sometimes we curtail our thinking because we're so used to what's always happened. Above that, there'll be a level of locality working where PCNs will start to come together in slightly larger groups, and that's where we get our integrated care providers. And then eventually we get what's called our ICSs, in effect similar footprints to most of our CCGs, integrated care systems, but that's also pulling together not only the CCG, but it's also pulling together some of the local authority and the social care back into it, because what we then want to get to a place is where we can start to see that as we start to invest in public health initiatives, actually the system as a whole benefits, and it's not public health having to pay for something that the CCGs get the benefit. So as you can start to see, that pyramid ring brings it right up as to how it all starts to join together. And at that level, then actually across the whole system, we're working together. And our ICSs absolutely then start to pull into our secondary care establishments as well, which is fantastic. Okay, so that's really what I want to talk about. That's been great being able to chat to you about that. What I'd then like to do is, if I stop sharing the presentation, and equally, if any of you do want my contact details, happy for you to take those down if people want to contact me after it. But if I then stop sharing my presentation, and I'd be really interested to see what sorts of comments and questions people have to take us through the next, 15 minutes or so. Okay. All right. So at this point, feel free to put things into the chat box. So I can see a question from Catherine. Are these figures Avon specific or national? I'm assuming you will refer, well, I don't actually know, were you referring to DMS or were you referring to CPCS? Well, I can answer the question for both. They're all related to the Avon services. However, I'm led to believe for both services that replicates what is actually happening nationally. What else have we got from you? And how much of an issue is it in general that a GP can advise a patient to attend without following the pathway, i.e. not a true referral, and you don't do without a fee? So this is the CPCS service. If a GP practice just sends a patient on an ad hoc way, it can be a real issue. There's a couple of things with that. Is if a patient is referred through an ad hoc means of just pop down to see your pharmacist and they'll see you, then actually there's no referral and the patient can fall between the cracks again. With the formal referral to the pharmacy, it means the pharmacy knows to expect the patient to turn up, and if they don't, then they have to follow up with them, and that's right. Equally, a summary of that consultation will then go back to the GP practice for them to have it on their notes. So it's absolutely right that as we move forwards, we have correct care pathways that mean that we formally handhold a patient from provider A to provider B. It always amazes me that we informally are quite happy to send people from a surgery to a pharmacy, yet you would never send somebody informally for an MRI scan, for instance. We don't send people informally around the rest of the system, but we seem to do it in that way. So I think definitely safety netting the patient correctly is really, really important, and that's about the correct referral mechanism. Yes, obviously that means we do then get the payment, but that's also correct if we're going to move our pharmacies into a world of receiving payment for professional services. So that's also right. Okay, let's see what else we've got. Piece around from Julia. Idea of minor injuries, A&E minus referrals. What work did you do with the local GP practice, CCG? So I've got really good relationships with my CCG and also with my NHS England team. And I've been pushing for a while now as part of the current 111 First programme that's running to encourage systems to actually start to look at making more of the referrals. So we're hoping that, there'll be a national pilot at some stage to look at minor injury referrals and ED referrals. That's a national NHS England project. It's on our work plan as a national contract. And hopefully that will start to come out in the coming months as being possible for pilot sites to be set up. So it's a bit of a watch this space on that one. But again, it makes absolute sense. The community pharmacist consultation service is like an umbrella service for all sorts of different people to refer into community pharmacy. What we got? DMS has been launched in the middle of a pandemic. What allowance assistance has there been to support the hospital sector in driving the referrals? Yeah, I think that's one of the big challenges. I absolutely recognise from talking to my colleagues in my acutes, of which I have three main ones. I have University Hospitals Bristol, North Bristol Trust, and the Royal United Hospital in Bath. That is the big challenge. Certainly my acutes are now looking at an automated system so that there'll be meds rec on admission will be where we can send the patient into the service and also identify which is their community pharmacy of choice. And then when they go through discharge at the other end of the process, it will be in the same way it's automated to send something to their GP practice. Because you then know which pharmacy to choose to send it to, it'll be automated as well to get it sent across to the pharmacy. Absolutely, I completely agree with you. If you could have chosen a better time other than doing it to launch the service in a pandemic, it would have been great. But sometimes timing just goes against you. For me, it's about how we move forwards with the service and how we start to work with it. And hopefully, seeing some of the delegate list, I know there's a number of hospital pharmacists who are present during today's conference. I think it would be fantastic for people to go back to their hospital setting and see where you're all at with the discharge medicine service and find out whether if you don't already know, find out whether it's something that you can get involved in, because that genuinely, that safety netting absolutely absolutely works, and hopefully then we can move beyond it being difficult at this time of the year. Another one from personal experience, there's a need to increase awareness with those on the ward who are facilitating a discharge. Yep, completely agree with you. We actually had another case in Yate, which is in North Bristol, tiny village, where a patient was discharged after having a myocardial infarction. The only difficulty is that they were in complete denial about that fact. They refused to believe they'd had a heart attack. As a result, they were not going to take any of the medications they'd been given. Community pharmacist intervened with getting a discharge summary. This was a number of years ago when it was the TCAM project. Contacted the patient, still in denial, contacted the surgery. The surgery still at this point had no record that the patient had been in hospital. So the community pharmacist went and spoke to the hospital pharmacist, who did some research, confirmed that absolutely the patient had been in and had had a heart attack and absolutely needed to take the medicines they'd been prescribed. At this point, the community pharmacist was able to raise it back again with the surgery, who found the discharge summary and realised that actually they did need to intervene, and then got the patient in and dealt with the whole piece around their denial and everything. And then obviously the patient understood what had gone on. But if it hadn't have been for the tenacity of that community pharmacist and for the support they received from their hospital colleagues, this patient was not taking their medicine. It wasn't even a matter for debate. They just didn't believe that they'd had it. So another piece of good evidence as to why this service is important. But you're right, for increasing the knowledge base of the people on the ward about this service is also really important. Do you give the acute trust any feedback with the DMS referrals? They say, Richard. With the license that our hospitals have, they now have the pharma outcomes license. As a result of that, they get the data file. So they can download a patient tracker, which shows them all the information that they need. And in fairness, that's the same patient tracker as what I've downloaded to show you some of that data. So if they get the right pharma outcomes license, absolutely, they can get all that data that they need to be able to see. Community pharmacy is changing. Any evidence, evaluation of what's happening at a national or PCN level to improve perception and engagement of colleagues in other areas of practice to support the uptake? Yeah, Philip, I agree with you. We're doing a lot of work in Avon at the minute. I have a primary care relationships manager whose sole role is to grow and develop the relationships between my hospital, between my pharmacies and my surgeries. And we're also looking to extend that to build collaborative training sessions with our hospital colleagues as well. We're doing a huge amount of work to continue to build that. I think sadly at the minute, community pharmacy gets a bit of a bad rep and has done for a few years. And we've seen a migration of our community pharmacy workforce moving out of our sector and moving into potentially general practice. To be fair, I think hospitals have been seen in the same way, and they've lost a few people, I think, to some of the primary care roles that are coming out. So there's quite a big drive, and certainly some of the national lobbying now is also about improving the perception of community pharmacy so that people realise that we're moving more into clinical services, which is good. David asks, what's your view on the education and development need for community pharmacy to support this significant change? How do we integrate education for services, i.e. CPCS, into an integrated development pathway? Move towards an integrated education process. So yeah, Health Education England, I think, have got a lot to do in this. HE has supported for many years now. A lot of you as hospital colleagues have very little input into the community pharmacy programme, and I think that's important that starts to be addressed, and certainly in the Southwest we're starting to address it. There are some things, though, that we don't need to necessarily increase the skill level of our pharmacists to do. So let's take CPCS as a great example. CPCS is about community pharmacists seeing patients that are not any more complex than patients who would walk through the door. It's just where that individual has chosen to access the service. So in some instances, we don't have to increase the knowledge base of our pharmacists. Sometimes we have to increase the knowledge base of other professionals that wrap around us. So how do we increase the knowledge base of our surgery colleagues to trust the fact that the pharmacist will look after the patient in the way they expect? That's probably a bigger educational piece that we need to do, because when they end up in the pharmacy, actually the pharmacy looks after them because they do it day in, day out. So there's a number of things that go with that. It's about educating, I think, the whole system. What we probably have to do is raise the confidence levels of our community pharmacists. I think there are some of our colleagues that have forgotten some of those clinical skills. And if I'm honest with you, I went back and did the community pharmacist postgraduate certificate, and it reminded me of some of those clinical skills that I had tucked away that I'd not used for a number of years. So I think a lot of what we have to do is actually grow those confidence levels. Malik, from your experience, do you think that community pharmacy could ever become a pharmacy service only contract, especially with the new digital age? Data sharing is a priority for ICS and dispensing become more automated through robotics and dispensing hubs in the community. Yeah, you know, that's an interesting one, isn't it? And it's a debate that rages quite significantly. I think the safe and effective supply of medicines to patients is still crucially important. And come what may, the public still expect to be able to visit a pharmacy in the vast majority of cases, as we sit here today, to access those services. Yes, we see the increase of maybe online, or we see some of the automated systems, but you know, the vast majority of patients still want to be able to visit a pharmacy. Now, I'm not daft enough to think that that isn't changing over time as, you know, people who are more digitally competent, you know, who buy things, you know, great example, you know, my wife, everything is now bought on Amazon, whereas though you go back 10, 15 years, we would have shopped on a high street. So consumer trends are changing. So it's always about having an eye on what will happen in the future. You know, but the pharmacy contract then has to continue to develop. And I think the fact that in a few years' time, all pharmacists are going to come out as independent prescribers, I think only lends itself to a case where we may see more, you know, more pharmacies looking like what you can get on the continent, where, you know, if my children get an ear infection when we're in Spain on holiday, we will present in a pharmacy, that pharmacist will have prescribing rights to be able to sort them out with some eardrops. So it is interesting to see where it's going, but at this moment in time, the supply of medicines is a crucial part of what we do, and currently that needs to all be hooked in together in the way that we manage it. And let's not forget, the reason why we have some of the lowest drug, well, the lowest drug bill I think in the world, is because of the work that community pharmacy has done over the years to drive down the cost of procurement. You know, now those savings end up in the NHS, which is great, but it's because of the way that community pharmacy has bought in a very clever and savvy way over many years. And, you know, some of those benefits wouldn't have been realised had we not had that commercial interest in pharmacy. So fine balance as to where that one could end up, I think. Are there any localities, Are there any localities developing read-write access to System 1 by community pharmacies to ensure digital integration? I'm not certain about System 1. EMIS, because there's quite a good link with EMIS and ProScript, I believe that they're starting to look at some things around being able to do it. I have got some pharmacies that actually do have a GP system, or the GP system, in their pharmacy, because obviously most of these systems now can operate in a cloud-based way. So rather than thinking about a pharmacist having read-write access as like some additional functionality, probably think about it more in the sense of a community pharmacist having the GP system in their pharmacy. I know a couple of community pharmacists who are also independent prescribers who literally on their laptop can put their smart card in and they dial into EMIS Web. So possibly those sorts of things are already happening. We talk about things like summary care records and some of the integrated care records that they were looking at having local health and care records. What they do is they suck information out of a variety of different portals and they place it into a viewer. And the difficulty there is if you're extracting information to then make it available as a viewer, writing to that database up here doesn't help you, because what you've actually got to do is write to the database that's in the local environment, and that's much harder to do. So it may be that we move to a world where actually pharmacies have some of those prescribing systems available to them. Over time, we're starting to get community pharmacies hooked up with much better systems so that they can actually pull down some of this information, which is useful and will move us forwards. It's also interesting to think, I mean, I've got a number of hospital colleagues that would also love to be able to access things like EMIS and System 1 in a hospital setting as well. So I think lots of people are crying out for access to those records. Northumbria, we're driving development of DMFs with community pharmacy colleagues. It's progressing well and a good example of collaborative working. It does help that WAS is helping to drive this. Yeah, fantastic. I'm over the moon that that's then starting to progress for you. And then the last question in there is actually, we've got 10 minutes left of this session, which now means we've got 5 minutes left of this session from when that was in. Philippa, just comment, perhaps the personnel moving from community pharmacy into general practice might act as insiders to change the perception of pharmacy. Yeah, you know, actually, Philippa, I think you're absolutely right with that. I think general practice, you know, doctors and nurses that historically have worked in general practice had a very one-sided view in some instances around what pharmacy stood for, and I mean that across the whole profession. I think with the advent of these roles, they're really starting to see the added benefit that can come from working closely with a pharmacist. I think that part of that, though, is the way that pharmacists have managed those relationships with other professions. Sometimes as pharmacists, we're very good at telling people when they've got something wrong. Now, from our perspective, what we perceive that to be is, I've saved their neck because I've pointed out a potentially fatal prescribing error. But unless you've actually got a relationship with other parts of the multidisciplinary team, if all you ever do is point out things that they've done wrong, although that is saving their job potentially, you've not got much in the emotional bank account for being able to do that all the time. So I think as much as anything, I think as pharmacists, we have to recognise that we need to build a relationship with the multidisciplinary team to also be in a position to actually then show the things when they've got them wrong. And I think that's what pharmacists who have now gone into to general practice have been able to do, and have done really successfully. They've really been able to push forward the benefit of working closely with pharmacists for the huge value they bring to that patient care.